Yeah. We are live now.
Yeah.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Safe Motherhood, organized by Indian Association for Sexology. So it's my privilege. Before starting the webinar, let us start the webinar with Tamil Taiwan.
திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்து எந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
It's my privilege to introduce the convener of today's webinar, Dr. Jairani Kamaraj. Ma'am is the Senior Consultant of Reproductive Medicine and also Director of Akash Fertility Center and Hospital, Chennai. Ma'am is currently the Joint Secretary of TNFOG, Vice President of TAPISAR, Past President of OXY, and also South Zone Coordinator for No to Wow Committee. I welcome you, ma'am, and I hand the session to you.
Thank you, Sahiti. It gives me great pleasure and honor to welcome our chief guest, Dr. Narendra Malhotra, sir, and my dear friend and the guest of honor, Dr. Preeti Kumar and Dr. Kiran Mai, and the senior faculties and my dear madam mentors, Dr. Suchitra Pandit, madam, my dear Charmila, senior faculty, and all the senior friends from Uttar Pradesh societies, from by Dr. Meenakshi Sood, Dr. Nidhi Bansal, Dr. Sangeeta Roy, Dr. Saira Madam, Neha, and all the senior members from Tamil Nadu Federation also, and my dear friend Dr. Kundavai, who is the speaker. I welcome you one and all, and a very, very warm welcome to Dr. Shobha and Dr. Aruna Suman, and all my dear friends. So it gives me great pleasure to welcome you all to this Safe Motherhood webinar, which is we want to celebrate on this May month, which is a Mother's Day month, Mother's Day celebrated month. So for the safety of the motherhood, we want to have some knowledge which has to be improved, or we have to get the latest regarding the safety of the motherhood. So with this in mind, we have this webinar organized by the Indian Association of Sexology and the Tamil Nadu Obstetric Societies and the UP Societies, which we are going to discuss mainly about the prediction and prevention of PIH. And also we are here to how to manage any high-risk pregnancies and give the mothers safety. So with this in mind, we have this webinar and we have the senior faculties here who will be sharing their experiences, expertise, and knowledges in this field. And I welcome you all for this webinar. So as a formal inauguration, we have the great pleasure and honor on behalf of Indian Association of Sexology. I welcome the chief guest, Dr. Narendra Malhotra, sir, who in midst of his busy schedule has accepted to be a part of this webinar to be the chief guest. And sir, don't need any introduction. He's a well-known international personality with so much of knowledge, wide experience, lot of work he has done in the reproductive medicine and also in the longevity and also the aging, which he's passionate, and lot of newer things he does every time when we meet him. Every word that he says is a newer thing about the human life, and it is real inspiration to see him working on so many focuses related to the human life. So we welcome you, sir. As a formal introduction, I would like to introduce sir. He's the director of the ART Rainbow IVF Center, managing director in the Global Rainbow Healthcare, and he's the director of the Foxy Smriti Manyata CSE, and he's the vice president of the Society of Ovarian Rejuvenation, director Project Positive Health Rotary District 3110, and director International Relations Suffolk, and national director of the Iron Donald School of Ultrasound, professor of the Sarajevo School of Science and Technology from Croatia, and he is the professor of the Dubrovnik International University, Croatia, IMA, Indian Medical Association professor, and he is the past vice president of CEPHOG and WAPM, past president of the Rotary Club, past president of almost all the national societies like ISAR, ISPAT, IFOM, FOXY, AOGS, ICMU, and INSAG, and he is the founder editor of the CEPHOG Journal. And Sir has authored more than 125 papers and 300 chapters, published over 500 presented papers, and over 1,000 guest lectures he has given both in India and international and abroad, 62 orations to his credential, and 37 published papers, and over 356 keynote lectures. I think Sir would have done some Guinness record in all these achievements. Sir, we need at least 3 days to read out your CV, sir.
Thank you.
And I'm very honored and blessed to have you as a chief guest, sir. Over to you to say a few words of your, your words of wisdom, sir, to us.
Thank you. Vanakkam. So, greetings to all those who have joined from the UP societies and to the Tamil Nadu societies on this webinar. We know that education has now changed and it has become mostly on the screen rather than meeting physically. Physical meeting is equally important, and I think we should be meeting. But so lucky that we can do all the academics sitting at home, sitting in your bedrooms, relaxing at the time, sometimes in your OPD and everything, and keep track of what is going on. So that is the new normal in education which COVID has given to us. So that I congratulate all of you, especially Alpesh Gandhi, who started the digital education programs with Foxy. Now, congratulations to you, Jaya, and to all the experts who are here on organizing this webinar on a very, very important topic. Yes, May is the month for so many days for women. Mother's Day, Menstrual Hygiene Day, International Women's Awareness Day, which was just 3 days back. So 3 or 4 women related days are there. Though I believe all 365 days are for women. Maybe half a day for men somewhere.
Sir, but here in so many, ladies, you are the star. So whatever the days doesn't matter.
I'm there because I'm a ladies' doctor. So, yeah, today we have doing this on Safe Motherhood, and you see, I see Preeti here as the guest of honor. So much work has been done by in Foxy and Safe Motherhood. So when she was the chairperson, and what she's doing in CEPHOG, Safe Motherhood Committee. And the topic we are going to discuss is PIH. And I see Suchitra is there. The gestosis core is being highlighted so much, which all of us should be following. I talk to so many people. Do you do a gestosis score? No, we don't even know. It's such a simple score which has to be done and will give you a whole good idea of how to manage PIH and how to save our mothers. And small interventions like calcium, magnesiums, and all can prevent a lot of problems. And then I see that AMH is being discussed now. Today we are facing a low AMH epidemic. All our young girls in the 30s are coming with AMH less than 1. I mean, it is shocking how premature ovarian insufficiency is highlighting in India. It should be less than 1%, but I think it has gone up much more. So how and what AMH can do or tell about your reproductive life is very, very important again to be discussed. And of course, I see a fantastic panel discussion on risk scoring on high risk pregnancies, which I'm sure will bring out a lot of points on how we should be managing high risk pregnancies. It is a day of high risk. It is an era of high risk pregnancies. Every pregnancy today seems to be at high risk. Even if it is going simple, it is high risk from the attendant's point of view. So something happens, they are a very high risk factor. So that is another high risk which we are facing today, the obstetricians. So congratulations to all of you, to all the people who are going in for the election this year. Charmila, Jay Rani, Bharti, all of you, best of luck to all of you. And I'm sure that you all will do very well. And Foxy does need all of you. Thank you very much for inviting me.
Thank you, sir. Thank you so much for your inspirational talk and throwing out a lot of things about the motherhood. And we are really proud to be a women and almost all proud to be a Foxians and working for the women's health, sir. Thank you so much for your words, sir. I have the great pleasure and honor to welcome our guest of honor, Dr. Preeti, who is a good friend of mine, a very dynamic person I know in Foxy, who has really worked a lot to the community. And I'm really have a very, very happy and very emotional mind with Preeti, because she really does what we need. What as a gynecologist, what as a person who loves the community, what a woman who loves the women's health should do. She has done a lot in her Safe Motherhood Committee chairperson. And I'm really hats off to you, Preeti, for the wonderful work you have done for the PPH and the maternal mortality, morbidity awareness, so many things you have done as a committee chairperson. Thank you so much for joining us as the guest of honor. And I'm very proud to have you. You are the Vice President-elect of Foxy. And can I have the CV of Madam? Preeti, Madam?
It's okay, Jairani.
No. We need to introduce you. So she's the professor and head of the Department of OBGYN Society of the Narayana Institute of Medical Sciences, Kanpur, organizing secretary of the UPOG to 2023 in Lucknow, ACOG Lucknow 2020, Lucknow Justosis 2019, and IAG 2018, and also the NZ
North Zone
YF, North Zone UF Foxy, 2017 Lucknow. She's the vice president of the Lucknow OBGYN Society.
No, it's an old one. It's now president.
Sorry,
it's okay.
It's good to have you, Preeti, and we would like to have your wishes and your inspirational talk to us.
So thank you, Dr. Jairani. First and foremost, I would like to welcome you all to UP societies. I'll not welcome people who are from UP, but definitely from Tamil Nadu and other parts of the country, those who have joined today. Thank you for joining hands with UPCOG. And I'm sure this webinar is going to be a great hit because you have selected a lot of good topics, as Dr. Naren sir has mentioned. And you know, if you see the recent statistics now, PIH is the leading cause of maternal deaths, and it's not the hemorrhage. So hemorrhages in many states is coming to the second, as a second, commonest cause. PIH is the most common cause of maternal deaths. And first and foremost, Dr. Jairani Kamraj, a few words for you. I've seen you working as the president of Oxy. I have attended the conference which you had organized. The kind of work and energy and the passion you have, people like you should come up in Foxy. And I'm so happy that Dr. Kiran Mai is there. Dr. Kiran has done a lot of work, and, we thought what she will do in WOW, but definitely under the guidance of Dr. Shanta Kumari, and because it was her vision about the Dhira, No to Violence Against Women committee was launched, and Kiran Mai did a lot of work in that. And I'm sure that you will pursue the same committee with great passion, and lot needs to be done for this committee. So good luck to you and all the contestant. I've seen Aruna is there, Dr. Bharti is there, a lot of people are there who are contesting. So good luck to you all. And recently we had a webinar with Karnataka Society, and happy to share that Gestosis with, I think Chamila is here. Karnataka state, they have already included in the antenatal card the Gestosis score. So these are small steps that when we take and when we talk about the Gestosis score, it should be implemented in each and every facility, because this is the simplest, prediction for the PIH. So I wish you all the good luck, and I'm sure that the discussions will be very helpful and insightful. Wish you all good luck, Jairani. I really pray that you come up as the chairperson, and I humbly request everyone to please support her candidature for this election. A genuine candidate. Bharti definitely is from UP, and thank you so much for inviting me as a guest of honor. Thank you so much.
Thank you, Preeti, for your kind words, and thank you so much. And really, I assure you, I will definitely carry out your words in mind, and really look forward to work with passion like you in the committee if I've been given an opportunity. Thank you so much, Preeti.
Jairani, just want to put in a word here that we are now going to start working in Northeast. The Tripura we have selected because we got the call from Tripura to do some work, because 25% of the maternal deaths are happening because of anemia, PIH, and PPH. So I raised the fund from Bill Gates Foundation, requested Dr. Sunita Tendulkar and Dr. Bhaskar Pal to take it ahead. So probably by next month, we are going to launch this Tripura mission, and we will be training the public and private facilities. Lot of hemoglobinopathies are missed there. The BPs are not taken properly, so most of the women are landing in cardiovascular failure. So as a committee, just my take from here is that whatever responsibility you take in Foxy, it's very important that we reach out to the grassroots, where there is an actual need for the women of a country. So thank you once again, and wish you all good luck.
Thank you, Preeti. Thank you for all your, words. That is all the things that you bring about the women's reality life in India, and definitely we need to work a lot, and definitely we'll all join hands to achieve this. Thank you so much. So I have the great pleasure to welcome my dear friend and the committee chairperson of the No to Violence Against Women Committee, a woman who is so simple but very strong in heart, and who does everything with passion and perfection, and really who is a women who just work into the women's everyday life, how the miseries they go through, and such a passionate person who works in the Foxy. Another person whom I really love and look upon, Dr. Kiranmai Devani. She's the professor of the OBGYN Society of Vadarpati, and also she's now the dean in charge of the same college, and she's the vice president of Obstetric Gynec Society of Hyderabad 24-25, core member of Foxy No to Violence Against Women Cell 23-24, a core member and the coordinator TOT and faculty of the Foxy Dira Initiative of Stop Violence Against Women, the scientific vice chairperson of the ACOG 2024 Hyderabad, and organizing secretary of GCUOG and Foxy FIGO Conference Hyderabad August 2024, national corresponding editor for Jogi in 24, TOT UNICEF Gender-Based Violence Training and Survivor Centered Engagement Skills. And she has got a lot of awards. A few among that is the Kamini Yuva Rao Orator Award. Yeah, over to you, Kiran, for your words of wisdom.
First of all, many thanks for having me. It's a huge honor to share the stage with our most loved president, past president for Foxy, Dr. Narendra Malhotra sir, and also Dr. Preeti, as you have said. She's, I think, one Foxy luminary who everyone looks up to, and it's amazing work that she keeps doing. It's very difficult to emulate her, but it's very inspiring to see Dr. Preeti work every day for the, as she said, for the grassroots level, the real work. I mean, every day, every single day. So thank you, Jaya, and you are again a very energetic, passionate, and very happy and pleasant personality who is all positive vibes that you carry, and the indefatigable energy. I have seen you work in PMFOG and OXY, and also in the committee for No to War. As you have said, and as I rightly agree, there's so much still to do for the committee. The committee, the first 3 years, it's the first term, but there's still a lot more to do. We have tried our best. We have tried and I think succeeded to put the committee in the limelight, though it is a very new committee. Everybody recognizes the committee for the work that it has done for the past 2.5 years. So I really wish all the good luck and best wishes, and you are the right person to be the committee chair in the Notuva and also future Foxy World. And coming to the webinar today, again, very, very important and interesting topics. I think the future belongs to the prediction and prevention of preeclampsia. We have heard very eminent scientist Dr. Anand Karpanchi in the presidential conference at Vizag regarding the bedside test of SFLT and PGLD, how it is being made into cost effective, and also the treatment part of it. So I think the future belongs to, we hope to look forward to a day where preeclampsia is preventable, and definitely will not no more will be seeing the complicated and the severe preeclampsias and eclampsias. And AMH, of course, you are the better experts in the infertility field. And the third panel, again, led by Dr. Shobha Puri Madam, very support. Dr. Charmila is there, and again, it's huge honor and privilege to be with Suchitra Madam. Again, Suchitra Madam is very, very passionate about preeclampsia, we know, but she's also equally passionate about no to violence against women. Madam feels very emotional, and she has a lot of this thing in both the topics. Madam joined many times in the committee also. My best wishes again to you, and good luck. Thank you, Jaya.
Thank you, Kiran. Thank you so much for your kind words. And Madam, I just want a few words from Suchitra Madam. Madam, it will be really great honor if you can share your words here, because I want your blessing also, because you are the person who is really working a lot with the PIH as the Gestosis score and everything, which is very, very useful in the clinical practice. I'll be really happy to have your words, Madam. Ma'am, unmute, ma'am.
Yeah, thank you first of all for inviting me here as an expert. But it's great being, sharing anything to do with safe motherhood, because I think Foxy basically our vision and mission is, take care of the women, take care of their health and the future, which is our young children which are born. And therefore, very aptly, the topics that you've chosen, absolutely wonderful topics, because all of them are important from the point of view of looking after their health. And very rightly, we like our women to be healthy, but we also like them to be free from any kind of violence. Every day in the papers, in the WhatsApp, you see so much of cruelty being done to women. And you want that, women should not accept anything in the form of physical, verbal, or any kind of a sexual abuse, and must start speaking up. And we, as the I would say the protectors of women's health, we have to crusade against this big fight. So let them live safely and free from violence is what our motto should be. So safely from the point of view of their health, whether it's diabetes, whether it's PPH, whether it's PIH, or for that matter a simple thing like anemia. Let's build up their health. And Jerani, I wish you all the best for your future endeavor. And I'm sure that this time, you will definitely succeed, and we all will support you all the ways. And also, congratulations to Preeti. She's always done wonderful work. And Narendra was my president when I was vice president in his year. So I always look up to him, and we've worked together on so many different projects. And of course, when you're talking about say no to violence, must also thank Shanta for, we all knew about it, but Shanta sort of got it to the forefront, and then naturally, it was carried forward so nicely. So, congratulations to the entire team, and Jerani, all the best to you.
Thank you, ma'am. Thank you so much, ma'am. Thank you for your kind wishes, and thank you for accepting our invite to be the expert for this, because no one is there now in the country to say the expertise of this VIH prediction except you. That's why I just have the privilege to invite you, and thank you for accepting my invite, ma'am. Thank you, ma'am. Thank you. Thank you so much. We'll move on to the academic sessions. Sahiti, can I have the slides of the first chairpersons? I have the great pleasure and honor to welcome Dr. Nidhi Bansal, who is a gold medalist from SN Medical College, Agra. She is the secretary of the Agra Menopause Society 21, 2021, and she's the secretary now of the Agra OBGYN Society, and she's the executive member of AOGS, and she is the consultant of the SR Hospital, Agra. Can I have the next chairperson? Yeah. We have the great pleasure to welcome Dr. Meenakshi Sood. Madam is the life member of IMA. She's the founder member of the Sood Hospital, and she's the senior consultant of the OBGYN Society consultant, and she is from KGMC Lucknow, and she's the president of President 2023 and 2025. Yeah. Madam from Aligarh, and she's the master trainer of the HPV vaccination, and her special interest is adolescent health and high risk obstetrics. Madam, we welcome you, madam. Over to the chairpersons to introduce the speaker and the expert. Madam Meenakshi Sood, madam is there.
Yeah, it's my great privilege, Jarani. I never thought that you're such a pleasant personality. Interacting you for the first time. Wish you all the best. And again, I am a proud senior of Dr. Preeti Kumar, in KGMC. So I am a proud person today to hear so good about you and sharing the platform. So now I have to introduce such a versatile personality, Dr. Suchitra Pandit, consultant department of OBGYN, Surya Group of Hospitals, Mumbai. She is Foxy representative to CFOG 24-26, co-chair NCO committee CFOG 2024 to 26. She is an international representative of organization Gestosis. She is chairperson AICC RCOG 2017 to 2000. She was 2020. She is President ISOPAP. She was 2018 to 20. President Gestosis Indian Association 2016 to 23. President Foxy and ICOG 2014 to 15. And President Mumbai Society of OBGYN 2013 to 14. She is professor and unit chief TMMC and LTMG Hospital, Sion, 1988 to 2009, PG teacher for 39 years. And she conducted various researches.
Meenakshi,
She
Meenakshi,
initiated
Meenakshi
Foxy
ji, thank you.
Gestosis.
Thank you, ma'am. Thank
Suchitra,
you very
that's
much.
a long, long, long list.
Yeah. Thank you
And
so much.
wish you
Thank
all
you.
the best. And go ahead
Thank you
with
so
your
much.
talk. Okay.
Madam, you have to introduce Charmila, madam, too, ma'am.
Yes.
Meenakshi, ma'am.
Dr.
Kindly
Charmila
introduce the speaker, Dr. Charmila. Yeah.
She's Vice President Foxy 2024. Charmila, you are so charming. I'm looking at you, not your CV. Okay, but it is my duty and honor to introduce you formally. She's Vice President Trichy OBG Gynae Society. She's Chairperson Clinical Research Committee, Foxy 2016 to 18. She's ICOG Governing Council Member 2021 to 25. National Coordinator UNICEF Foxy PCA MEDA Foxy PG Program ISAR Gurukul Program 2022 to 23. Series Convener ICOG Journal Club and ICOG Certificate Courses 2022 to 23. WHO Southeast Asia Region MDSR India member. She is President Menstrual Hygiene Management Consortium 2018 to 20. She is Secretary Gestosis India Association and Academic Wing of Assisted Reproduction Trichy, and she is MC member PCOS Society of India.
Thank you. Thank you, Meenakshi ma'am. Thank you so much for that very, very kind introduction. Respected Dr. Suchitra Pandit madam, our mentor in so many fields. Thank you for your joining today. And I'd like to thank Dr. Jairani Kamaraj ma'am for the opportunity. And as Dr. Meenakshi said, she's a very, very pleasant person, and she was long due for a post in Foxy. And we hope that this will be the entry for her, so that people in India should also know that we have got a very, very capable person in Tamil Nadu, Chennai, and she's destined for so many great things. All the best to you, Jairani ma'am. I would like to just start my talk. And Madam has given me a talk on prediction and prevention of PIH. And nobody else can be an expert other than Dr. Suchitra Madam when it comes to gestosis per se. And it's an honor to be in a program where Madam is the expert. And why do we think that stopping this disease is very important? We have to remember that preeclampsia affects almost 8% of pregnancies worldwide and remains a major cause of maternal and neonatal morbidity and mortality. And FIGO in 2019 came out with 3 measures which they said can prevent preeclampsia. And for that, the most important part was the public health focus on this disease. The second was universal screening, which every health provider should be knowing. And the third is the prophylactic measures, which can prevent preeclampsia. And when we estimate a patient's risk of developing preeclampsia, it will help us to know like whether this patient is going to be a candidate for a heightened pregnancy surveillance and whether she needs some prophylactic measures like low dose aspirin, calcium, and exercise, which can help to prevent this disease. We have to remember that preeclampsia is a syndrome with several presentations, so there's nothing like an ideal predictive test. And that's why we need to combine many predictors together to identify whether a patient is prone for developing preeclampsia. And the pathology lies in the abnormal presentation and its vascular supply. But you have to remember that any pre-existing maternal subclinical endothelial dysfunction, like autoimmune disease or a chronic kidney disease, can all exacerbate, and the mother can develop preeclampsia during her pregnancy. And due to these assumptions, all the studies for prediction are focused on the maternal vasculature and early pregnancy, and that combines the history of the mother with measurement of her blood pressure, the measurement of her uterine Dopplers and serum biomarkers, which can all help to predict the development of preeclampsia. The most important and the most cost-effective tool which we have in India now is the Foxy-Gestosis ICOG hypertensive disorders in pregnancy GCPAR in 2019, which advocated the gestosis score. Because universal screening is recommended for every one of our pregnant patient, but there's nothing like one single effective screening test. And all the tests which have been proposed till date can predict the at-risk population, but they cannot be qualified to be recommended for a general population screening. And that's why at this point of time, assessment of clinical risk factors will help us to be more vigilant while identifying the development of this disease. And it's a very, very easy tool to do, and that can be done by any health worker using the HTP gestosis score. And regarding the other guidelines regarding the clinical risk factors, almost all the guidelines also advocate a maternal history, which will help us to predict this disease. And according to the American College, the NICE guidelines, the International Society for Study of Hypertension Pregnancy, and the United States Preventive Task Force, all of them have said the patient had a history of eclampsia or preeclampsia in the past. She's going to be at a high risk for developing preeclampsia in this pregnancy. Any previous adverse pregnancy or a perinatal outcome also will add on to a risk, according to the American College and the United States Task Force. Chronic hypertension, type 1 and type 2 diabetes, GDM, kidney disease, autoimmune disease will all place her at high risk of developing preeclampsia in the current pregnancy. And regarding the moderate risk factors, nulliparity is a moderate risk factor according to all the guidelines. A high pre-pregnancy BMI will place her at a moderate risk of developing preeclampsia. A family history of preeclampsia will also place her at a moderate risk. A multifetal gestation, according to the American College, will be a high risk factor for developing preeclampsia, but it's a moderate risk factor as far as the other guidelines are concerned. A mother who's older and more than the age of 35 will be at having a moderate risk of developing preeclampsia. And a history of low birth weight of the mother is also a moderate risk factor. And suppose there's a long interpregnancy interval of more than 10 years, it's a moderate risk factor for the mother developing preeclampsia. The International Society has added some more risk factors, and according to them, a BMI of more than 40 is a high risk condition. And a current pregnancy, which has an assisted reproductive technology condition, pregnancy is also a high risk factor for her developing preeclampsia. Moderate risk will be a prior stillbirth, a prior abruption, a prior fetal growth restriction. The strongest predictors, according to the International Society, is a history of prior preeclampsia and a chronic hypertensive patient. The Fetal Medicine Foundation has excluded chronic kidney disease and a prior abruption and fetal growth restriction as a risk factor, but it has added one, and that is racial origin. And what do these predictors say? Suppose the mother has got one high risk factor which is positive, or she's got two moderate risk factors, she's at high risk for preeclampsia. And that's why the gestosis score is quite, it compiles almost all the guidelines, and it gives a score of 1, 2, and 3 based on the category of risk the mother has for developing preeclampsia. And according to the Gestosis score, if the score is equal to or more than 3, the mother is at high risk of developing preeclampsia. And the other tool which is easily available and that can be doable in any low resource or high resource setting is a measurement of the blood pressure of the mother at every visit when she comes for her checkup. And even though it is not, preeclampsia is diagnosed only after 20 weeks of pregnancy, early measurement will establish the patient's baseline blood pressure and will give us an idea of whether the mother's blood pressure is increasing beyond what is normal. The measurement of the mean arterial pressure is quite an easy test to do, and MAP value between 70 to 110 is considered as normal. Even though as an isolated marker, it may not perform well, when it is added to the mother's clinical history, it will give lots of value to predict the development of preeclampsia. And according to the American College and the Royal College, there are 3 things which you will do to predict the development of preeclampsia, and that is obtaining a routine blood pressure measurement during every visit to the mother, a very detailed medical history, and a baseline screening for urine protein content to assess the kidney status when the mother comes for her first visit. And historical risk factors, just taking the mother's history, will predict only 30% of patients will develop preeclampsia. And that's why there are many studies which have now combined laboratory tests along with imaging tests, along with the history of the mother to calculate the risk of developing preeclampsia. And that is an active area of investigation for many societies also. But remember that the tests are all based on the pathology that preeclampsia is due to abdominal placentation and its vascular supply. And any pre-existing maternal subclinical endothelial dysfunction will exacerbate when there's a high risk for developing preeclampsia. And that's why any study which has been done has all focused on the maternal vasculature in early pregnancy. And that's why the mother's history is very important, with the measurement of her blood pressure, the uterine Dopplers, and serum biomarkers all are combined together for the prediction of preeclampsia. So the combined test will be a mean arterial pressure measurement of serum placental growth factor, uterine artery PI. All this will add on to give a better prediction of preeclampsia. But it is not easy to measure placental growth factor in any setting, any low resource setting, because it's quite an expensive test and it's not available in many centers. And measuring the uterine artery pulse PI also needs an expertise. And that's why even if you can't do the biochemical and the biophysical test, you can at least do a metal risk factors with MAP, and that will add to the prediction compared to doing only a maternal risk factor assessment. And suppose you've done a PAPA as a part of a routine first trimester screening for fetal aneuploidies, probably you can add that for a risk assessment for preeclampsia. But the main test which has been done in many countries, well-developed countries, is the patient risk estimation with biochemical, biophysical, and the maternal history. And that is all calculated using the Bayes-based method. And any mother is considered as high risk when her risk is more than or equal to 1 in 100 based on the first trimester combined test, with combined with the risk factors of the mother, the mean arterial pressure measurement, the PLGF measurement, and the uterine artery pulsatility index. But the combined test is predictive of only the development of preterm preeclampsia, but it's not predictive for the to predict the development of term preeclampsia. But the most important test which has come into the picture now, and it's quite useful for prediction, is the PLGF. It's a best biochemical marker according to the Royal College also. Any mother who shows a lower PLGF in her first trimester is supposed to have a higher risk of developing preeclampsia compared to a mother who's got a normal PLGF in her first trimester. The uterine artery pulsatility index is the measurement of the resistance to blood flow in the uterine arteries, and it is correlated to histological studies and the clinical severity of preeclampsia. A persistent high impedance to flow in the uterine arteries is evidence of poor placentation, and that manifests in the form of abnormal uteroplacental flow velocity waveforms. And when there was a study which compared the sensitivities of the different modalities of prediction of preeclampsia, and when clinical markers alone were taken, they predicted only in 34% of patients who were developing preterm preeclampsia. And as far as term preeclampsia was considered, 39% prediction was only done. But when they combined a maternal, a biochemical, and a sonographic evidence at 11 to 13 weeks, the prediction for preterm preeclampsia was 75%, but for term it was 47%. But if you do either PLGF or uterine artery PI, that itself is equal to 70% prediction for preterm preeclampsia. The SPREE study in 2016 also said something similar. That is, if you take only the clinical risk factors for prediction, screen positive is 10.3%, and the prediction for preterm preeclampsia is only 40%. But if you do the mini combined test where you combine the maternal risk factors, the measurement of MAP and PAPA, the prediction for preterm preeclampsia goes up to 53.5%. And suppose you add placental growth factor to this, it adds on to almost 69% prediction. And if you add a uterine PI, it adds on to almost 82% prediction for preterm preeclampsia. But we have to remember doing a uterine Doppler velocimetry in the early pregnancy is not a very good test for prediction because it can be a false positive rate and can lead to excessive patient anxiety and healthcare cost. And the recommendation is not to do it in early pregnancy. It is actually has to be done at the end of second trimester where it is more accurate. And usually it should be done as a part of a combined test. Other lab tests like an unexplained abnormal PAPA, which you see in your first trimester screening for aneuploidy, or a circulating cell-free DNA and microRNA, which is higher, that can also predict an adverse pregnancy outcome, which includes preeclampsia, but it's not specific for preeclampsia. But these associations are not sufficiently strong to warrant changes in routine prenatal care, but the biomarkers can be utilized for risk prediction for preeclampsia. Each risk factor, when you want to use, will be a separate screening test. And when you have a higher number of risk factors, it will carry a higher risk for development of preeclampsia. And that's why the Fetal Medicine Foundation has created a tool to predict the risk of developing preeclampsia early in pregnancy by using all these variables. And according to them, when they did this, when they combined the first trimester screening algorithms, it predicted preeclampsia at the range of 75 to 92%. And this is the FMF calculator which is being used in high resource settings. The disadvantage is you need to have so many tests being done with additional costs and complicated logistics, and you need people who know how to do the testing as well as the algorithm has to be, you have to feed the variables quite clearly to get a proper prediction. And it did not predict as high as it was claimed compared to doing only the clinical risk factors. And that's why the NICE guidelines from 2023 has just suggested that adding PLGF-based test will be much better to predict preeclampsia and also rule in or rule out preeclampsia between 20 to 37 weeks of gestation, not for early pregnancy. And it will tell you like whether this mother is going to progress to a severe category of preeclampsia when you have some parameters which are pointing towards her developing preeclampsia. And when this was implemented, there was a lower incidence of maternal adverse outcomes because we know now that we can wait for a period of time before you deliver the mother. The PLGF is quite normal. And what about rescreening for risk when you've done an early trimester screening? It may not provide better evidence, better benefits because it can just add to a surveillance which you already started, and using a tired approach of doing it again and again may not be beneficial, but probably an individualized approach can be undertaken to rescreen the mothers. But doing a justosis score in the first trimester, second trimester, and third trimester is not going to add to the cost of prediction of preeclampsia. And these tests of no use at all. And those are the biophysical tests which were done earlier, like the angiotensin 2 challenge test, the rollover test, the isometric exercise tests. They're quite time consuming, expensive, and most importantly, quite unreliable. And uric acid cannot be used as screening tool for predicting preeclampsia. Screening for inherited thrombophilias like APLA may not add to your risk prediction. And screening for antiphospholipid antibodies is also not beneficial at all. And that's why FIGO has brought out this recommendation, and they've said universal screening is needed for all pregnant women for the prediction of preterm preeclampsia, and that has to be done in the early pregnancy. And it has to be a one-step procedure, and that will combine maternal risk factors and biomarkers. The Canadian guidelines and the International Society has said in early pregnancy, at least at a minimum, screen the mother for clinical risk markers, which will not add to the cost of prediction. But if the testing is available, you can combine the clinical risk markers with the uterine artery pulsatility index and placental growth factor to individualize the risk of developing preeclampsia. The American College Task Force has said, till now, they have not added the biochemical marker. They've said a risk factor estimation is enough to consider to predict a mother developing preeclampsia. So after prediction, what are you going to do? According to FIGO 2019, this mother should be put on aspirin prophylaxis, and that has to be started before 16 weeks of pregnancy, ideally between 11 to 14 plus 6 weeks. The dose advocated is 150 milligram, and that has to be taken every night until either 36 weeks of pregnancy, or when delivery occurs, or when preeclampsia is diagnosed. The ASPER trial is the one which brought out this dose of 150 milligram, while earlier we were using the 75 milligram. But the limitation of this study was it did not compare 150 milligram of aspirin to 75 milligram of aspirin. It compared 150 to placebo. And they said when you use 150, it resulted in a reduced incidence of preterm preeclampsia. And they also provided evidence that effective screening can be achieved with a combined test and aspirin treatment from the first trimester of pregnancy, and that will reduce the development of preterm preeclampsia almost 62%. And suppose a patient is allergic to aspirin, this patient needs more frequent blood pressure monitoring or home blood pressure monitoring, and a close vigil needs to be kept on the patient, and expectant management is quite appropriate. And when the intake of calcium cannot be assessed or predicted, it is reasonable to give calcium, because there's a blood pressure reducing effect of calcium, and that's because of the alterations in the plasma renin activity and parathyroid hormone, which calcium does. And exercise also should be advocated to the mother when she's at high risk of preeclampsia. She should exercise at least 3 days per week for an average of 50 minutes using a combination of aerobic exercise, strength, and flexibility training. And this has been associated with less weight gain and reduced incidence of hypertensive disorders. And there are no significant adverse effects of exercise in pregnancy. And the gestosis, the GCPR of 2019 was, I've said, the optimum dose of aspirin is still unclear, because there are several studies where you use 60, 75 milligram, 100, 150. But low dose aspirin has shown a very good maternal and fetal safety profile. And the number of patients exposed to doses over 100 milligram is still low. And the safety of prevention based on 150 milligram of aspirin is still not confirmed. And that's why the GCPR has said that aspirin at a dose of 75 milligram, which is readily available, is quite enough for the prevention of preeclampsia. And it has to be started even earlier than 12 weeks, because defective placentation is considered as a causative factor of preeclampsia. And when you give early aspirin, it balances the levels of thromboxane A2 and prostacyclin, and that will maintain adequate uteroplacental blood flow, will improve the placentation without increasing any risk of adverse maternal and perinatal outcome. And it is safe to use low-dose aspirin as a prophylaxis to prevent preeclampsia throughout pregnancy until 2 days prior to delivery or a cesarean section. And according to the International Society, the dose can be between 75 to 150, but preferably should be started before 16 weeks, should be taken at night and continued until delivery of the mother. And these are not of any use. Primary interventions like bed rest, restriction of activity, reduced salt intake, on use of antioxidants like vitamin C, E, garlic, marine oil. And also the secondary interventions are not of any use, or the use of diuretics, progesterone, nitric oxide, metformin, statins, esomeprazole, heparin, all that have not been proved to be of any use for the prevention of preeclampsia. So how to improve outcomes? According to the SMFM, general measures which are needed are an access to quality care, and every systemic and community factor which impacts health outcomes should be addressed. Innovative care delivery models should be invested in, and all the guidelines should be context appropriate, and they should be adapted according to the country of origin. And specific interventions which are of use is magnesium sulfate, use of antihypertensive drugs, use of urine dipstick test, and functional blood pressure machines. And the patients need access to, and paramedical workers should be trained in the appropriate utilization of all these agents. I'd like to conclude by saying that this disease of unknown etiology still has a very low predictive value of the current screening test, and there are several presentations of this disease that it complicates the prevention of preeclampsia. And any intervention you do will help only in a small reduction in risk, and it means that you need to treat a very large group of women to prevent a single case of preeclampsia. So at present, the definitive treatment remains delivery and removal of the placenta, and no effective prophylaxis for preeclampsia is formally advised currently. They are all only as studies. Thank you so much. I'd like to wish Jairani Madam for her elections.
Madam, over to Chairperson, Madam.
Suchitra Madam.
Madam, yeah,
Yeah.
madam, yeah.
Okay, I'll just say, yeah, that thank you, Sharmila. She's extensively covered the entire prediction and how do you, what are the newer methods and what is the advantage of combining all the factors and giving a better prediction. I just like to once more say that coming from the Gestosis India Association, we found that this Gestosis score, it took us nearly 2 years to get everything ready because it has 27 factors which are based on maternal history, and she's already mentioned about what those factors are. But if this score, people always say that it's difficult to calculate, but it is not. This score is available, can be downloaded from the Play Store of an Android phone. Currently we don't have it on the iPhone, but you have a link, and we will send you the link, and if you just click on that link, automatically all the, that entire paper comes on, which where all the factors are there. So once you train your juniors, your doctors, or your nurses who are helping you in the maternity, or your whoever is there, if you teach them how to use the score, it takes less than 3 minutes to calculate the entire score. And if it's three or more, as very rightly she's mentioned, you start off with the calcium as well as low dose aspirin. Now, I wanted to also say that this score is dynamic. Of course, the advantage of starting aspirin before 20 weeks is very, very clear. Before 16 weeks is even better. But later on, say in the second trimester, 20 weeks onwards, if you do this score and the score comes out positive, you know that this patient requires more vigilance. At that stage, adding aspirin will not help, but at that stage, you know that this patient either needs to be shifted to a tertiary care center, or if you're already in a tertiary care center, maybe adding that PLGF. Now, there are many labs which are coming with the PLGF split ratio. In fact, the S split PLGF ratio, if that ratio is less than 38, you know that the outcome of the pregnancy is not terribly bad, and you still have 1 week to take care of the patient. But if it is anything more than 80, you know that this patient may have an sort of imminent severity of the preeclampsia, and you can transfer this patient to a tertiary care center. So that is, the score is very dynamic. It can even be used in the third trimester. So this score tells you a lot, easy to use. And one more thing which I'd like to say, that Karnataka government has already accepted it. I'm sure other governments, when we're planning to do this with different states, and I'm sure others will also adapt it. It's already published in the Jogi Journal. One more promising test which I'd like to say is the WHO Congo Red test, which has been currently, the two randomized trials have been done. Of course, there are small sample sizes, small, being done in Bangladesh as well as Mexico. And it has shown that they are able to statistically significantly predict the preterm preeclampsia. And therefore, that Congo Red is very simple test. Anybody can use it. It is based on the principle that if a patient is going to develop preeclampsia, then her urine has got certain proteins which will turn red with this Congo red dye, and that these azoproteins will give a positive test, and then you know that this patient is at a high risk for preeclampsia. So we are looking forward to this test. And one more thing which I'd like to appeal to all of you who are here, that PPH is being controlled, the risk ratios are coming down, but PIH is on the rise. HDP is what we call it now. So be on the watch out. And also importantly is education of the healthcare workers. And I'm talking not just of the gynecologists, I'm talking of the doctors who are there in peripheral hospitals. And there was a very nice survey done by a medical college where women who had preeclampsia were asked questions about how was your treatment, did you know about it? And 60% of them said that we did not know what high BP is. Nobody talked to us. They just told us to get admitted. So we would have been happy had we known more about it. So I think this is something for us to learn, educate our patients and their relatives, particularly the mother and the mother-in-law, about this particular problem. And that if the BP is borderline, please keep this patient under the red surveillance. Let her come back to you more frequently. In bigger cities, patients are able to buy the BP machine, which is the aneroid, or the simple machine which has to get calibrated, or they have access to go to the family physician and take their blood pressure, so they needn't be admitted each time. And if you find that the BP is 140/90 on two occasions, please don't hesitate to start off the antihypertensive treatment, because the early treatment means you are intervening and you're helping in the reducing the adverse outcomes of the high blood pressure. So with this, I think I'd like to
Madam,
close, and I'd like to say,
actually,
yeah,
Congo test is being done in AIMS also. That's what Aparna Sharma said. They said they are
right, but
bringing it.
yeah,
They,
but it is not yet, WHO has not yet said it is to be used for general, use. We are waiting and hoping that it is, it will be. Maybe they're still under, they're
They
doing
must
it
be
because
doing
the
studies.
aims,
They must be
yeah,
they're
doing.
doing
because
so.
the
They said they're
aims
going
is
to
still,
publish. That's what.
Yeah.
yes. Yeah, I think once WHO gives us a green signal, that will be a great test to use. But honestly, please use the Justosis score. All of us here, Charmila is the secretary of the Justosis India Association. Preeti is the joint secretary. I've been the past president. Alpesh is currently the president. And we have Dr. Sanjay Gupte and Dr. Gorak Mandrupkar and Girija Wagh all backing this, this Justosis score. Please use it. And this time in FIGO, we have a full session. We have to thank our international, president, who is from Bangladesh, and Chief Dr. Firdausi Begum, and she has actually planned an entire session on, preeclampsia and how to prevent eclampsia in the FIGO thing. So those of you who are attending, please do come, and we intend to popularize the score, particularly in our low resource settings. So I'm sure all of you all will agree, and thank you very much. Jairani, once more wishing you all the best and wishing all the contestants the very best for this election.
So,
Thank you.
Chitra ji, there is a hand raising by Dr. Meenakshi Sood.
Yeah.
I want to say something.
Yes, please.
Yeah. Because I want to tell you by my experience, I have been working in the rural setup for 20 years and I have seen eclampsia every, other day. So always I write down also lines. So I want to give a message that whenever a patient comes for infertility or other problems like post marriage UTI or anything, like if we are doing pre pregnancy counselings, then there is a very catchy sentence that's drive your BMW safely. Everybody wants to dream of BMW. So BMW is keep your BMI under check from 25 to 27, keep your mean arterial pressure from nearly 100, and your waist circumference should not increase, because we are fighting with PCOD and all other things because of increased waist circumference, because of lack of pelvic exercises, lack of physical activity. And safety is in justosis score. If we can give this message to all our health workers, and we can sort of counsel every patient who's coming for us to us for infertility treatment or other things, I think we can prevent PIH more effectively. I mean, predictors are there, but prevention is more important. So thank you so much for inviting me for this
Word,
wonderful
ma'am.
session.
BMW.
Thank
BMW
you,
is a very
madam. Thank you.
catchy word.
Thank you, madam. Thank you so much for your kind words. And Madam Suchitra, madam, once again, thank you so much for emphasizing the importance of the justice score, which we all should take forward in every rural area, even for the all the practitioners to put into it, so that we can have a better prediction and better prevention of this condition. And I really appreciate Charmila and yourself working on this justice. Society is very good. Rather, you are doing great work. Thank you so much, madam. Thank you so much for all your kindness.
Thank you.
Thank you so much, chairpersons, for your. Uh, I mean,
Preeti is also.
yeah, Preeti.
Just,
Preeti,
Jairani, can I just
yeah.
ask one question from Dr. Suchitra? Charmila, your talk was excellent as always. Dr. Suchitra, just one question for the audience. Suppose if a patient is a case of a woman is a case of a chronic hypertension, and she's on antihypertensives and she's found to be a score of more than 3. Will aspirin work in such cases? Should we start aspirin? Because International Society of Hypertension says that aspirin in such patients is not so preventive for development of preeclampsia. So your comments on this?
Yeah. See, when the patient is already chronic hypertensive and she's already on some particular medication, obviously we are going to shift over to a safer medication. But even in these patients, because they are already subject, they all that there's some pre-existing pathology. We don't know what that pathology is. It could be chronic kidney disease, it could be some kind of an antiphospholipid antibody which has caused that, some autoimmune thing. So in all those cases, in fact, they get higher scores of 3 and more. And chronic hypertension is one of the factors which gets a score of 3. So I would still strongly recommend, please use low dose aspirin for whatever it's worth, because you don't want to prevent, you want to prevent the superimposition of the preeclampsia on that. So it may have better, low dose aspirin may have a better effect in preventing preeclampsia in a primate than in a chronic hypertension who's probably already had a child or who's chronically hypertensive and wants to get a pregnancy. But yes, if this patient gets a higher score, and in fact, I would suggest, please start it rather than just wait. Please start it.
It's similar to coronary
International
heart
Society
disease, no?
says that
Yeah.
it is not so helpful. So starting aspirin in such cases will not help much.
But
No, no. Yeah,
guidelines they have not mentioned, no? I
Ma'am,
don't think it's
should we
yeah.
increase the dosage? Not
No.
like
No,
the
no, no.
75?
No.
Can we increase? Yeah.
See,
75
currently,
is
yeah,
recommended.
we're sticking to 75 currently. Can I tell you, there is a very recent study which has been published in 2024 BMJ, and this is a study by AJ Romero and all, which says that the use of micronized vaginal progesterone in women who've had a severe preeclampsia in the prior pregnancy, along with the preterm delivery, in those cases, if you start micronized vaginal progesterone from the first trimester itself, it reduces not only the incidence of preterm labor, but also the incidences of preeclampsia.
I
And they
think,
have a
Suchitra, you should also mention about the promise in the PRISM trial where
yeah,
progesterones were used as a
that's
secondary.
what I'm, no, this is a secondary outcome of the promise
Yeah,
and
secondary.
progesterone trial. So
Secondary.
the primary outcome was, will it prevent recurrent pregnancy losses? And the secondary outcome, so AJ Romero took all these studies, some 9,700 patients, and some of them are meta-analysis, some of them are RCTs. He's analyzed that entire thing, and he's mentioned this is a useful drug and use, because micronized vaginal progesterone may help. And I think that was probably the basis of the recurrent pregnancy losses. So that's where it helped, and they said it also reduced the incidence of preeclampsia.
Just one more question, Dr. Suchitra, before
Yeah.
you leave.
Yeah.
Are these biochemical markers, as you mentioned, like the split ratio and PLGF, are also predictive of postpartum severity after the delivery also?
Yes, actually, if you've done it before, you are more prepared and you know that this may go into a severer form. But if it has never been done before, if you do it just immediately post delivery, you may get a correct value. But if you do it, say, 2 weeks later, you won't have a value because the placenta is already gone and the S-flit levels will go down. So the predictive value is best in the antenatal period, particularly, after 24, 25, 26 weeks. But immediately, say a patient is delivered, she's come to you as an emergency, and you quickly send it and the patient is delivered, you may still get a correct value. But once the placenta comes out, then the S-flit probably may not have so much of a predictive value.
Thank you. Thank you so much.
Thank you, madam. Thank you for the nice interactions, and thank you, Preeti, madam, for putting into a lot of practical aspects of PIH management, which is really a lot of mind blowing and a lot of insights into it. Definitely, we need a lot of research related to our sector of women, and definitely, you are the people who can take that into whatever level you want. Thank you, ma'am. Thank you so much for the nice interactions. We are moving on to the next second session. I have the great pleasure and honor to invite and welcome the chairpersons for the second session, Dr. Sangeeta Roy. Madam is the professor and head of the Department of OBGYN Institute of Medical Sciences, Banaras, Hindu University, Varanasi. She has done a PhD in cytogenetics on female infertility, and also she has done a fellowship in FICOG and academic and clinical interest. She being the professor of the head of the Department of Banaras Hindu University, and she's the president of the Varanasi Obstetric Gynec Society 24-25, vice president 23-24, and secretary of the society in 2019 and 20. And she's a life member of IAG, SFM, IMS, ISABA, AGOA, and also she's the Foxy Manyata assessor. And she's the scientific chairperson of the IAG 2024. We welcome you, Madam Dr. Sangeeta Roy, to be the chairperson for this session. And I have the great privilege and honor to welcome Dr. Zehra Mohsin. Madam is the professor of the Department of OBGYN from JN Medical College, AMU, and her special interest is gynec oncology and high-risk obstetrics. She has for her publication around 35 publications and chaptered in 2 books, and she has a paper presented and done more than 33 guest lectures, and she had a lot of conferences and workshops organized, and she has supervised 17 theses of her thesis for the students. And we have another chairperson here, Amrita Chaurasia. Madam is the secretary of the Ghaziabad Society of OBGYN Society, and she's the assistant professor of the Christ University. We welcome you, chairpersons. Let me hand over the chairpersons. I don't know who has joined. Everybody's name is coming as Kundavi. I don't know who has joined. Is Sangeeta Rai Madam is there?
So, okay, I am Dr. Zehra. I'll introduce.
Yeah, Madam Zehra, Madam. Yes, Madam.
Can you hear?
Yeah, ma'am. We can hear you, ma'am. Can I have the CV of Madam and yeah.
So can I please have the CV of the speaker?
Yeah, so Kundavi, yeah.
So thank you so much. I have the honor. First, I want to thank the organizers for having us here for this webinar today. So I have the honor of introducing Dr. Kundavi Shankar. She is a senior consultant at Lead Fertility, and she's also the vice president elect of Tapisar OB-GYN Society. She's the honorary secretary and the academic secretary also of the Tapisar OB-GYN Society. She is a member of the Fertility Preservation Committee, an IFS Achiever Award in 2023, the ISAR Dronacharya Award in 2023. She has FNB and MMM fellowships programs to her credit. She's chairperson POSH committee. She has many publications in reputed journals, and she's been invited faculty at various national and international conferences. So I now request her to start her presentation. Thank you so much.
Thank you, ma'am. Thank you for the nice introduction, and thank you, Jaya, and all the best for your election. Can you see my slides?
Yes, Kundavi, you make it as full screen.
Yeah.
Yeah.
Today's talk is going to be on AMH, the practical implication, and let's see whether it is a game changer. We know that the AMH is a gonadotropin independent, and it's a critical for physiological evolution of the Mullerian ducts during sexual differentiation in the male fetus. So AMH is clinically useful as a screening tool for diminished ovarian reserve and the hyperstimulation as well. When you look at the various levels, the high levels maybe is for PCOS more than 4, and the low levels may be 0.5 to 1. And I think we have to be very, very careful by looking at the conversion factors, what they come out. So if it comes as picomoles, probably 7.14 into nanograms, you get the proper values. But I think age-specific AMH level is very, very crucial, because the woman comes to you at the age of 41, and if she's got an AMH of 0.5, I'm sure she will respond much better rather than cancelling the cycle. So what are the clinical applications of AMH? You have an ART, fertility preservation, the ovarian neoplasms, PCOS, the pediatric endocrinology, and prediction of early menopause. And let's see what the evidence says. We know that we have got various indications for do an ovarian testing, like women who are running infertility evaluation, the PCOS, those are donors, perimenopausal with BRCAs and everything. But there are various factors where AMH can get affected. Like, for example, in the PCO, it is on the higher things. Whereas when you have an history of ovarian surgery, it comes down. In endometriosis, it comes down. And when they're on the ossiples, it goes down. And probably on a low vitamin level, it also AMH goes down. And people talk about there is no intracycle or interpersonal variations in AMH, but I think the recent studies have found that the serum AMH levels were significantly lower in the late luteal phase compared with an early follicular phase, but it has got a minimal impact on the clinical performance. But also, we also should know about the different AMA assays, and DSL is the latest one. And let's start the evaluation of the ovarian reserve. It is now the most sensitive marker of the ovarian reserve in the general and in the IVF population. And it also helps for the personalized ovarian stimulation. It also chooses to help you to stimulation protocol so that it reduces the hyperstimulation on one side. On the other side, it helps in prevents the cycle cancellation from the non-responders, leading us to closer to the realization of the personalized fertility therapy. And what about AMH in the age of 40 years? In the first IVF treatment, people have found that if you have a cutoff level of 1 nanogram, AMH can be used to predict the ovarian response. Whereas on the other hand, our data has also showed that the patients over age of 40 with extreme low levels of AMH still had a chance of pregnancy. So probably in these settings, you can counsel them that they may and may not respond well, but you cannot tell them that they will not fall pregnant. Another thing is like, what about the clinical pregnancy? Does AMH can predict clinical pregnancy rates? We found that the most of the studies said, yes, it can predict the number of oocytes, but the predict the clinical pregnancies was a bit on the lower side. And when AMH was used as a predictor, setting as a cutoff level was controversial. And this Ku et al. Reported that the significant increase in time to pregnancy in a very low AMH levels, that is less than 1.9, they took a longer time. So overall, the utility of AMH in predicting the success of non-ART treatment may be useful only in cases with low AMH levels. These AMH levels are predicting pregnancy and live birth, but the prediction was very, very low. And this was a meta-analysis which said that they have a positive correlation between the serum AMH and the pregnancy in the fresh cycles, but not with the frozen cycles. And can AMH predict available supernumerary blastocysts? The answer was, if you have a AMH less than 1 nanograms, cryopreservation was very, very low when you have compared to the higher AMH levels. So regarding the miscarriage after the ART pregnancy, the meta-analysis again showed a higher rate of miscarriage in women with low AMH levels than in women with medium or high serum AMH levels. Does it have an impact on the oncofertility or the fertility preservation? Do we have to do a pre-treatment AMH levels or a post-treatment AMH level? Does it help the clinicians as well? The answer is like the pre-treatment AMH measurement can also assist in predicting the cancer therapy related amenorrhea significantly, especially in breast cancer patients. And these results can help physicians generate individualized risk of ovarian insufficiency and allow the patients to make a well-informed decision to undergo fertility preservation treatment or not. Again, this people have said that early identification of these women will likely assist the physicians in making a timely referral to reproductive endocrinologists so that the patients can have an open discussion regarding the available options for preserving their fertility and set realistic expectations regarding future fertility, which will also enhance the quality of life after treatment by orders of magnitude. So people have found that following a chemotherapy and radiotherapy, people have attained amenorrhea, and the patients over 40 years with undetectable AMH at the end of the cancer treatment often do not experience menstrual recovery for about 2 years after treatment, suggesting that the post-treatment AMH levels may serve as a predictive factor for ongoing amenorrhea. Another thing, there was no conclusive evidence regarding the correlation between the treatment of AMH levels and fertility potential. So found that 45 women were tested and 44 had a low post-treatment AMH levels, but 93% did achieve pregnancies later. So following that, what people said is, these findings suggest that the post-treatment AMH levels may not be reliable indicators of the fertility potential after cancer treatment. So you need to have a lot of investigations following that. So what about this pre-treatment AMH is going to be useful? Again, yes, a meta-analysis reported no significant association between the AMH levels and the development of ovarian insufficiency in the pediatric patients with different cancer types, because measuring pre-treatment AMH levels may be useful for predicting the menstrual recovery. AMH, does it have any impact on the ovarian neoplasm? Yes, it is identified as a tumor marker in an adult granulosa cell tumor since a long time, and the levels are elevated in nearly about 93%. So inhibition of the stem cell factor, activation of these apoptotic pathways, as well as an arrest of the cell cycle has been found as a checkpoint in an epithelial. And using a recombinant AMH holds a great promise as an investigational targeted therapy in epithelial ovarian cancers. AMH and PCOS, we all know that we use left and right in these women. And how does it help? Because we know that it did help to use during the to diagnose for programming the patients and the treatment profile as well. People have used this nomograms. When you have a high AMH, reduce the dose to start with only 150. And when you have normal AMH levels, and probably you start with the 225, and did help in order to reduce the hyperstimulation as well. So people have found a meta-analysis reported comparable ongoing pregnancy and reduced hyperstimulation in ovarian reserve testing based algorithms compared with the standard doses. So AMH-related program did really benefit the PCOS women by reducing the risk of hyperstimulation. So though the cutoff level of AMH in the PCOS was about 4.7, various studies have said it can go up to 7.9. And people, though there were a lot of controversies regarding the diagnosing PCOS in an adolescent, people found that if you have an AMH of 6 to 7, you can diagnose PCOS. And the metformin did have, and bariatric surgery did have, has been shown to reduce serum AMH levels in PCOS. And again, this has been used as an indicator for the efficacy of treatment of PCOS. Does it have an effect on the ovarian insufficiency and then reduced ovarian reserve? The answer was yes. The validity of AMH measurements for predicting ovulation or determining the therapeutic effects of infertility treatment in patients with ovarian insufficiency has not been established. And they found that the serum AMH, earlier we were using only FSH levels to predict the POI, but of late people said that if you use serum AMH levels, they are more accurate than serum FSH in diagnosing POI in early stages. So taken together, serum AMH is as effective for diagnosing ovarian insufficiency. And this is also another condition where they found that it is easy to differentiate from POI and the resistant ovarian syndrome, again, with the hypergonadotrophic and hypogonadism. And AMH levels which are low in POI are at a normal level in women of the same age. They are useful to differentiate between ovarian insufficiency and resistant ovarian syndrome. And again, AMH has also been used to differentiate between hypothalamic amenorrhea and ovarian insufficiency. And in patients with Turner syndrome, including mosaicism, the cutoff was low AMH was around 0.7 nanograms as such. So does it have an impact on the surgery? Does it help? So yes, the serum AMH levels pre-surgery and post-surgery was very, very helpful because it did help to counsel the patients as well. The pre-surgical serum AMH measurements may be useful to judge the risk of reduce ovarian reserve after surgery. And it also helps to choose appropriate surgical procedures to avoid a substantial reduction in the ovarian reserve. Again, it was little controversy because people found that the serum AMH levels can come back after 3 to 6 months, though it is on the lower side. And people know that the disease itself can reduce AMH levels in endometriosis. Does it have an effect in sexual differentiation? Yes. In 46XY fetus, the lack of AMH may result from testicular dysgenesis affecting both Leydig and Sertoli cells. In this case, persistence of the Mullerian remnants is associated with ambiguous or female external genitalia. What about in pediatric endocrinology? In females, it is required for the physiological evolution of the Mullerian ducts. In females, AMH can help to localize the source of virilization. Raised levels are found in testicular tissues. Induced virilization, which levels are normal in congenital adrenal hyperplasia, whereas in children treated with over-testis, AMH can definitely identify the presence of testicular tissue before and after surgical intervention. It's also used in Klinefelter syndrome as its levels reflects the degree of testicular dysfunction and this condition. So we know that the Turner syndrome are especially likely to undergo an accelerated depletion of ovarian follicles, and monitoring this AMH is an excellent indicator for the premature ovarian insufficiency in these patients. Again, it has also been investigated as a test of differentiating the hypogonadotrophic hypogonadism from constitutional pubertal delay. So now we have started with the adolescents to the reproductive. Now let's talk about the perimenopausal and the menopausal. Is it been useful to detect menopause? The answer is yes. The declining AMH levels indicate the gradual decrease in reproductive capacity with age, and hence they may be considered as a potential marker for menopause. Whereas another study reported that the combination of AMH and the age was more reliable predictor of early menopause than the age alone. Women above age of 40 with low AMH people have treated with DH supplementation probably improved ovarian function and the pregnancy rates and the decreased embryo aneuploidy and the miscarriage rates when they have an early menopause with low AMH. This was another study where they compared the AMH to the testosterone ratio to predict the positive sperm retrieval in men with idiopathic non-obstructive. If you have an AMH cutoff of 4, less than 4, and the AMH testosterone ratio of less than 1, they found that this particular group of men did have a positive sperm during following a surgery. Does it have an impact on the general population? The answer was yes, not only the infertile population, it did have an impact on the general population. And this a group of people have reported that the miscarriage corresponding to AMH levels were less than 1.1. So based on the conflicting results and the inconsistent study, the systematic review concluded that clinical recommendations could not be offered, but most of the studies found that if you have an AMH of less than 1 or less than 0.4, there is an increased risk of miscarriage in spontaneously conceived pregnancies as well. So probably as a clinician, we can take measures if you could prevent the risk of miscarriage. And this is another one which said that if you have a discordant, which is better, AMH is better or AFC is better, and they found that AMH is a better predictor of response compared to an antral follicle count. Again, if you have a low AMH with a decreased live birth in a discordant, which is better, they found that lower AMH is independently associated with the lower live birth and a higher cycle cancellation rather than an elevated FSH. So if you have a discordant AMH, AFC, and an FSH, you look at the AMH levels and then probably you can start the gonadotrophin dose accordingly. What is the ideal time to interval to retest? Probably they said about once in 3 months you can repeat the test. So finally, to conclude, I would say that the AMH is a game changer, starting from an pediatrics of differentiate between the gonadal dysgenesis and an androgen insensitivity, and you have a reproductive, the PCOS diagnosis in an ART helps you to stimulate your gonadotrophins, adjust your dose so that you can prevent hyperstimulation, you can prevent the cycle cancellation. It acts as the best ovarian reserve markers, and especially it helps in an oncotherapy because it helps you to counsel the patients regarding this future fertility potential as well. So I think AMH is a game changer. It has been effective in ovarian disorders. It has got a low intercycle, but I think probably it is better that you do it in the follicular phase rather than a luteal phase. Strong correlation with the follicle numbers. It helps you for an individualization of the ART protocols. And with the cancer survival coming up in a very big way, it helps for an oncofertility as well. And it is a diagnostic marker for PCOS because we use it left and right. It's a significant scope in assisting the diagnosis of disorders of sexual development in clinical pediatrics. Thank you so much, Dr. JK. I think giving this opportunity, and all the very best for your election.
Thank you, Kundavi. Thank you so much. And you've given a very, very extensive everything about AMH from A to Z, right from the adolescence to the menopause and to the IVF specialist and to everyone, rather all the clinicians, what they should know about AMH. You are given very elaboratively. As you rightly said, the predictor of the ovarian reserve is definitely AMH, but only one thing we should understand, it is not a direct predictor of fertility. Like if there is a low AMH, it doesn't mean that they cannot conceive naturally. They can still conceive naturally. Younger women with a lower AMH, they have definitely a better natural fertility, because nowadays we are seeing a lot of people coming with a low AMH and asking for, madam, will I get my baby at 26? I want a oocyte donation. Somebody said like that. So many of the gynecologists also feel that when there is a low AMH, they have to be going for either a third-party reproduction. So such sort of an thinking, or the prevailing thinking among the gynecologists, should be given a proper insight about this AMH, because low AMH doesn't mean that they cannot conceive naturally. It has been a strong correlation with the antral follicular count, which is very helpful for the ART specialist to plan their ovarian response and the ovarian stimulation. In that way, it is very helpful, but it doesn't mean that low AMH is a predictor for fertility. One. So in the clinical views, definitely the poor ovarian response, predicting the hyper response, choosing the proper protocol, your AMH has a very positive role. But in the oocyte quality as well as the pregnancy outcome, they doesn't have much of a role. But still, we can have an idea if there is a recurrent miscarriages, still a low AMH can play a role. And one thing is, we always nowadays start feeling that low AMH, it is more interpreted or rather misinterpreted among the clinicians, because many times they feel the low AMH has a decisive on their fertility. But one thing we want to say, younger women with a low AMH can conceive naturally, or even when they are subjected to IVF, their quality of the oocytes will be better when compared with the older women with the same amount of an AMH. That is one thing. And of course, PCOS, this is not a diagnostic thing for the PCOS, but definitely nowadays there are a lot of papers coming to say about the AMH value, its correlation with the diagnosis of PCOS, but it always indicates the increased follicular count which is seen in the PCOS patient. That is very important. And of course, as you rightly pointed out, nowadays the AMH values are low because of the lot of lifestyle factors like smoking and all the age, mostly the drugs, low BMI, all these things have an impact. And that is the reason even in very of the environmental pollutants causing a lower AMH because of its toxic effect over the endocrine disruption effect. And that is also very important. And we should have a proper automated assays when you give a value of AMH, because many a time the assays in the laboratory is variable, and this isoforms and these automated assays are being a lot of differences in the reporting. So that also should be standardized, and that should be taken into very important consideration. So as you rightly pointed out, the wrong impact of this AMH level related to the fertility outcome should be insisted to all the ART specialists, and the predictive value is very strongest in the ART protocols. So I think you have done a great job with so many things about the AMH, and I really thank you for that wonderful presentation, which is really very, of course, you are known for that. Thank you, Kundave. Thank you for being here.
Thank you, Jaya. And all the best, and God bless you.
Thank you. Madam Chairpersons, I think Zara Madam is there, no? Madam? Madam was there. I don't think that the chairpersons are there. Okay. So we'll move on to the next important session, the panel discussion. I have the great pleasure and honor to welcome the chairpersons for this panel, Dr. Vidya Chaudhary, who is the professor of the OBGYN department of Jhansi, and she is the president of the Jhansi UP Society. Madam has contributed one chapter, the second edition of the Practical Cases in OBGYN, edited by Dr. Kannan Elkar. She is the co-editor of Bulletin of Public Awareness Committee in 2016, and she has more than 20 publications in various indexed national and international journals, and has participated as faculty in many national, zonal, and state conferences. And she has been awarded the fellowship ICOG and ICMCH in 2013. We welcome you, Madam. And we have one more chairperson, Dr. Beena Singh. She is an alumni of 1983 batch of LLRM Meerut. She did her MD from the same college. She has an immense knowledge in her field and deals high-risk obstetrics, urogynecology, and other gynecological problems. She has been awarded the gold medal and being the best outstanding in academics. She is an expert laparoscopic surgeon. She is running her IVF center in Bijnor since 8 years and doing a lot in infertility. She is the owner of the Healer Hospital and Beena Prakash Hospital. She has attended many international and national conferences as a member of faculty member of Indian and American Reproductive Society. We welcome you, Madam. She is now the president of the Bijnor Society. Over to chairpersons. I don't know how Dr. Veena said that she has an emergency. Is there Dr. Vidya is there? Vidya Chaudhary? So if they are not there, I will be very honored to introduce the moderator of this panel, my dear friend Dr. Shobha Gudi. Can I have Madam's CV? Madam is a very dynamic chairperson of the FOXY Committee of the Family Welfare Committee, and she is the past president of BSOG and BMS, and she's the professor of and HOD of Saint Philomena's Hospital, Bangalore. She's a postgraduate teacher and examiner and consultant in the Manipal Sagar Excel Care Hospitals, and she's the assessor of the GOA project Lakshya and board member of FPAI, chairpersons for the reproductive health of Isobar, Endocrine Committee IMS, South Zone Coordinator of SBSI, and ECM member of Kasoga, and special interest being in high-risk pregnancy and menopausal medicines, endoscopy
Sorry,
and vaginal.
Jairani,
Yeah.
I was not able to unmute myself. Please stop. It's fine. I'm sure.
Yeah.
I'm sure
You
people
can-
are
you
aware
can-
who I
yeah,
am.
you- yeah, yeah,
And
I know that.
let me
It's
just,
my-
yeah.
It's
Yeah.
my honor to introduce you, Shobha, always.
Yeah. Thank
You can introduce your panelist. You can just name them.
Is it? Yeah, Bharti, welcome. I was waiting for you in the certification course contraception. At least here, you must make your presence felt. We had
Yeah.
just now concluded a three-day certification course on contraception and family planning from ICOG.
She said that she will join by 8 o'clock.
Yeah,
I
and Bharti was very much required there, but somehow I think she is very busy canvassing. They are all the last day, no, tomorrow. So probably, probably she is very busy with that. Next, who is there?
So you can.
Yeah, can I have? Yeah, Dr. Archana Singh from Moradabad, the past president. Welcome, Dr. Archana. Next, Deepali
Dr.
Verma,
Deepali.
President Moradabad. Arre wah. President is also there. Deepali, welcome. Yeah, and Neha Chandra, Secretary Moradabad Society. Yes, and Aruna Suman. Okay, so this is someone special, very, very close to my heart. No. Aruna is a really dear person, I think.
She will
Very
join.
loved.
She will join little later. Yeah.
Little
We are busy with the
later.
HR. Yeah.
Yes, correct. Okay, next, please. Everybody knows she was Joint Secretary in Dr. Shanta's year. Very dynamic person. Poonam Agrawal, welcome. President Firozabad Ops and Gynae Society. I hope you have all nominated as Jairani, all the presidents. And thank you for the nomination. I hope my message has reached. That is my main worry, whether my message has reached them, because it is so difficult to call up everybody. We would like to call, but it's so difficult. Next, please. Poonam, welcome very much. Dr. Gomati M, Associate from Professor from Madha Medical College, Kundratur. Where is this? This is Chennai.
In Chennai.
Okay,
Chennai.
in Chennai.
They're all
wonderful.
our federation.
Correct.
They are from
correct.
Oxy and
Okay.
TNFOG, yeah.
Okay. Next, please. Yeah. Welcome. And we
She's our
have
dynamic EC.
Karpagambal.
Yeah.
Sairam. Okay. She looks very dynamic
She's a
also.
sprint queen. She's a sprint queen.
Wow. Coming to know so many. Please sprint in the panel now. Let us see. Very fast you should be. Next, please. Yeah. Mohana Pramila. Okay.
That's our super dancer. She's the
really?
She's the Padmini of Vaijayanimala and Padmini of our Oxy.
Wow. Okay. Then I think she's close to my heart also.
Yeah, you are
Very
also a good
close.
dancer. Yeah.
Very close. Okay, Mohana, let us hope we dance together someday. And Kartika Prabhu.
That's a walking encyclopedia of our Oxy.
Oh my goodness, you are frightening me now. I'm really. I was thinking at 8:30, how will I conduct a panel? Okay, so let me now. Is that all?
Yeah. Yes.
Huge panel. Okay. Let me now share. Please enable me to share. And I have some very simple things, but they are all obstetric emergencies. So but that way they are complex, but in the means they're serious cases. But then they are all something that you would do every day. But I thought that let us kind of have something which people will find interested, because it is so late in the night. Let us put something dynamic. Then we can finish it quickly also if it is fairly straightforward. I'll just share. Sorry about the delay. I will just share. I'd not opened the presentation. I'm sorry. Hmm. This is something which I have done before, but I felt that it is useful for today's panel. So just case scenarios on high risk pregnancy. We will first take a case of HELP syndrome. The acronym of HELP is, of course, everybody is aware about this, and that this is one of the serious complications of severe preeclampsia, sometimes also found as an isolated condition. It is hemolysis, elevated liver enzymes, and low platelets. Sometimes all three elements are not there. So I will take you through this 30-year-old unbooked primey, 37 plus 6, pretty much term, but she just landed with us with severe preeclampsia, and she had some pain and upper abdomen, principally headache, and she was still getting good fetal movements, but she didn't have other signs symptoms of imminent eclampsia or of any real labor symptoms. She did not have. There was good urine output, and the pregnancy history was that she started manifesting hypertension around 30 weeks and was started on antihypertensive, the alpha beta blocker labetalol, at a reasonable moderate dose of 100 milligram twice a day, and she remained on that dose for till she presented to us. But when she came to us around 35 weeks, there was some mild FGR when we went through the scans, but the normal Dopplers, and hypertension at admission was 150, 110, and she had a mild, little smaller uterus, of course, unfavorable bishop, and then we saw that the CTG was normal. So we started treating her with the following investigations. The investigations we got was, a high LDH, and are these enough investigations? Can any of the panelists opine on any other investigation we would like to do for this case? There was a 3 plus albumin. Pretty much everything is there. Normocytic hypochromic anemia. The renal panel was normal, in case you are not able to see here. And the serology, of course, this was a little way back. So we had done COVID at admission, and her coagulation profile was okay. The LFT showed elevated enzymes and elevated LDH. So any inputs at this point of time? Plan of care, would you like to comment on? Panelists, you please take one by one. Let me not call out by name. Very quickly, quick responses.
There is definitely she is having an admission BP of 170, 110.
150, 110, yeah.
Yeah.
Yeah, 150, 110. May I know her gestation age, madam?
37 plus 3.
7. So it is a clear-cut case for termination. No other
Yeah.
second
Yes.
thought at all.
Correct.
On this
Mhm.
itself, we have to terminate. And
Yeah.
looking at the this lab parameters, definitely there is a HELP syndrome, elevated liver enzymes and low platelet. And if I know the previous hemoglobin, then we can say about the low hemoglobin and the hemolysis.
She's all unbooked, no dear. So not much of information.
So
Yeah.
it is giving
She started on Maxelf also. We started magnesium sulfate. We counseled NICU counseling also. We put in. We kind of started trying to induce her with the dinoprostone gel, since she was a primary gravida. But then we noticed that there was hematuria, and so we took her up for emergency cesarean section. Any inputs for the cesarean section that we are about to intake? Anybody else? Anybody can opine, please. Please quickly start talking, please. Yes, please. Yeah. Yeah, Kartika. Yeah.
In a patient with HELP syndrome, we can induce, but when she is going to develop, she has to deliver faster.
Yes.
So when there is a delay and she's going to develop complications, better to hasten the delivery process.
Yes. That's what we did. Yeah. No, during cesarean, you're wheeling her into the OT now. Any inputs now?
We have to make arrangements for all the coagulation products also to be ready. We have to be prepared to manage PPH. Atonic PPH is one anticipated complication which we usually encounter. So we have to make measures available. A senior obstetrician should be available. The blood products, everything should be made available before we start.
Correct, correct. So we must try and get these things ready, right? But we cannot delay unduly if the blood products are not there. We should still go ahead, and because terminating the pregnancy itself will give us some reversal of the complications. It will give us some normalization of the changes which have happened. Even if it is not dramatic, at least the process of reversal will start. So here the anesthetist preferred to give general anesthesia, though many give with a platelet of more than 1 lakh, many can still give spinal, but so that is okay. After that, there was postpartum hemorrhage. We encountered postpartum hemorrhage in her, and we did try all the oxytocics. We even had to put brace sutures for her and uterine tamponade with a condom catheter. The estimated blood loss was 1450 ml. So what are the other complications that can set in whenever you have HELP syndrome and the context of postpartum hemorrhage? What are the challenges now in this case?
You can go for multi-organ dysfunction.
Yes, but beginning with what? Yes, very correct.
It's difficult to close the
DIC.
abdomen, DIC,
Correct.
and
DIC
she
is
will
the
be
most.
bleeding. The same
Correct.
case I encountered in the morning. Actually, she was not a clear-cut HELP syndrome. Serially, the platelet decreased. That's all. The other thing is she's had a BP of 170, 110, and urine albumin 3+, and the proteinuria, 24 hours urinary protein was 8,000. So the nephrologist said it is in the nephrotic syndrome range. So you have to terminate her immediately. Otherwise, she may require dialysis in short. So I did the CBC in the morning and found that platelet was reduced by 20,000. So 1,80,000 in the admission time, and now it was around 1,40,000. For this platelet itself, I had a terrible time. She had a PPH. It is not a typical atonic PPH, but she had a ooze everywhere. Then I
Yes,
have
it
to
is
keep
possible.
yeah,
Yes.
I did a B lynch and I put a Foley tamponade. Then it
Same
stopped.
thing we have done
Then
here.
I
Same
gave
thing.
one
Thank you
blood
for
and
those inputs. Very
2
good.
FFP and 1 blood, and we saved the
Yeah, so I just wanted to say that the blood loss can be very brisk in such cases.
So
Both because,
many
you know,
cases
you,
we are not having the typical help, but
yeah,
even that this minimal decrease, reduction in the platelet may put us in our
yes,
this
I agree with you. So
situations.
in these cases, the replacement has to be very quick, and you have to identify the PPH very quickly. You have to give the corrective measures very fast. So we actually did a sandwich technique in this case to stem the bleeding. Gradually, the uterus regained in tone, but it started improving only after the PRBC were transfused, you know. And then because she did have hypotension also during the surgery, we kept an intraperitoneal drain, TDK, and we also kept a subcutaneous drain. We gave 2 pints of PRBC during the surgery and shifted her to the MICU. Now, in the post-operative period, can one of the panelists outline the post-operative management? In this case, let me quickly say that she maintained the hypotension. I mean, she took some time to normalize the BP. The tachycardia also settled only after we gave her PRBC, FFP, and you know, even random platelets, because STP was not available at that time, at that point of time, though single donor platelet is what is preferred. And when you have a blood loss of amounting to 1450 in a case with severe preeclampsia, it is better to treat her with a massive transfusion protocol, because they do classify as that, because they are severe preeclampsia. And patient was on oxytocics, and she gradually stabilized by day 1, and the platelet count started, no, it showed as 79,000 at that time, and then gradually she came back to 1.05 on day 2, and on day 3 she was actually stable. So what about the post-operative challenges? What else can happen in this case? I just want some more input so that we complete this disastrous picture, we complete the situation of all possible complications we discuss, and then we go ahead. Yeah. Anything else can happen.
Not audible, Dr. Gomati. Dr. Gomati, you're not audible.
Gomati,
You
your
unmute.
volume
Increase
the
your volume.
volume increase பண்ணுங்க. Increase the volume, Gomati.
Yeah. Or anybody else can also take up meanwhile as she's correcting. Gomati, start talking. Let us see. Start talking. Let us see.
Ma'am, can you hear?
Yes.
Yeah, little. Yeah,
Post-operative
now
care.
better.
Post-operative complications
Post-operatively,
in a case of health syndrome. Yes.
ma'am, post-operatively, she should be monitored in a ICU setup so that her vitals are monitored. Since she has suffered a hypovolemic shock, the perfusion to the vital organs like kidney should be maintained to prevent anuria because the kidney can go for irreversible necrosis. So urine output should
Very
be
good. I
monitored.
wanted you to highlight that this is a very classical setting for AKI, acute kidney injury, and all obstetricians should be very beware of this. So even as we are transfusing blood, we are doing so much effort. We must make sure that the renal function, the kidneys are protected. Yes, Gomati, go
At least
ahead. Go
24
ahead.
hours, we need to monitor
Should be more
hourly
than
urine.
30 ml per hour. And the BP should be maintained so that a systolic BP does not fall less than 90, so that will maintain the perfusion for the vital organs. So aggressive fluid therapy along with monitoring that she doesn't go for a pulmonary edema also. We have to be
Yes,
invasive monitor,
absolutely. Absolutely. So this is a very beautifully put by you. So what are the intensive care interventions which will help us to maintain fluid balance without putting her into overload?
Central vein.
Central venous pressure monitoring, invasive monitoring will be helpful, ma'am, along with the monitoring of the urinary output, ABG, coagulation profile,
Yeah.
D-dimer.
So here there is a role of POCUS, the point of care ultrasound, where they will be able to judge the amount of fluid deficit by checking on the IVC filling rate, the inferior vena cava. So that is one thing which has come up in a very big way. And of course, all intensivists are trained in this now. And today, a lot of improvement has happened because so you very rightly brought out the high risk of ARDS and pulmonary edema, which is refractory in nature, which happens in these women, and that can happen after delivery also. So unlike isolated severe preeclampsia, HELP syndrome takes more time in recovery, and they are more prone for complications for an extended period of time even after delivery. Very rightly put. Acute kidney injury.
Yes, ma'am. We don't know which side the patient might fall. So we have to monitor respiratory rate, coagulation profile, liver function, and mean arterial pressure and the CNS. So like putting a SOFA score, it will be helpful for us to assess the patient better she is hemodynamically stable or not.
Yeah.
In simple, hourly urine output should be monitored, and accordingly fluid can be given. Previous our urine output plus the fluids that will prevent us from hemo concentration or the going for a pulmonary edema. This we can balance between these.
A very close monitoring has to be done. I agree with you. So the thing is now, just a moment, and Dr. Sampath is calling for some reason. Yeah. Okay. Am I audible now? Yeah.
Yes, ma'am.
Yes. Any more inputs? Karpakam, you want to say
Yes,
anything? Yeah.
As all the complications have been mentioned, so HELP syndrome actually takes a bit of a time to recover because replacement of blood product, individual components is very, very important. So I really will ask the blood bank to be ready with all the components and most importantly, and avoiding NSAIDs in such situations. We are so used to writing post-operative pain relief. I will be very, very cautious in telling them that not write
Exactly.
NSAIDs.
These are the inputs which I want. And whenever there is a sitting of AKI, then you must avoid antibiotics which will harm the kidneys, like
Next was I was about to tell that antibiotics.
Absolutely. Very good inputs. Now,
because
the
we think
thing
of
is,
sepsis because patient has been in the hospital for a long time, ICU setting. So we all think of sepsis and we are just jump into broad spectrum
they
antibiotics.
are very vulnerable. What I wanted to highlight here about the AKI is already the kidneys are significantly compromised because of severe preeclampsia. A normal creatinine at admission and a good urine output should not mislead us. we should understand that the kidneys are delicate in her, right? And then the very good component therapy, very good maintenance of circulation will protect the kidneys. Otherwise, in this case, the loss was so brisk that she did suffer hypertension for some time. And actually, we were very worried whether she will go in for AKI, but fortunately, she did not. So what I wanted to highlight here is HELP, sepsis, AKI, ARDS, and other complications will set in. So that is the reason why we need to be very proactive in these. And all of you are very correct. The interventions, everything specified is very correct. But we do realize that all these, interventions are actually multidisciplinary. So even though the intensive team has to be perfect and has to be supporting for us, we must be aware of all this. We must have exact knowledge of all this. Because when it comes to talking to the family outside, better that you are aware of all these interventions. You're aware of which side this is going and what the intensivist is doing. Because actually, you should speak the same language that the intensivist is speaking. Yeah. So I think we are all on the same platform and all of us are speaking the same language right now. I'm very happy with your responses. So HELP can be a deadly complication. You do have about 10% at least of all severe preeclampsia as HELP. Am I right? Yes. Okay. But you also have a data which says that of all pregnancies, maybe 0.5% will have HELP. Maybe this is some data which comes up, or today the risk is increasing in pregnancy because of so many NCDs, etc. So we can believe that. So always we must be aware about this complication. So, and then there is that attendant perinatal mortality and maternal mortality is also, and it is very variable. So we'll not discuss that. What I want to know from the panelist is one, suppose there is a setting of hypertension, we are all very alert about picking it up. But otherwise, in a walk-in patient in the OPD, will you be able to suspect HELP? Any one of you, can you respond? Walk in, you are just doing your antenatal and she has come and your attender, your assistant or nurse or postgraduate, she has checked the BP and she tells you, madam, it is 130 by 80. It looks okay to me. Some mild edema is there. I did the dipstick, madam, it is negative for albumin. But the patient can have some symptoms. Can you tell us?
Epigastric pain, madam.
Pain can be there.
And
Okay.
this 130/80 BP, we have to check in the previous BP.
Previous, fine.
Sometimes she
Okay.
will be having 90, 70, 170.
Yeah, that is
Suddenly there will be a
significant.
130/80. So we
Yeah.
have to give importance
I
to
agree.
reason
I
the
agree. Yeah.
Malaise,
Anybody?
fatigue is
Anybody?
more common, ma'am. Malaise and fatigue, extreme fatigue,
Yes.
tiredness will be there, ma'am.
Yes. 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 Yeah. This is what I wanted to say. She doesn't look very anemic, but she's very tired. She's very tired. You cannot explain her fatigue. I think you should kind of investigate her more and get a peripheral smear, a CBC, get a platelet count, and then, keep a vigilance on her. You may not admit her, but keep a vigilance on her. So I wanted to bring that out. Very good. Have a high risk of suspicion for HELP syndrome. The outcome, it looks like this. All of you have told all these complications. Association of abruption is also very well known in HELP, very well known in HELP. And after delivery also eclampsia can happen. After delivery also press can happen. So please continue the magnesium sulfate for 24 hours after delivery, or if she has a fit, for 24 hours after the last fit. That I think everybody will agree and we can go ahead. And these are the usual fetal outcomes which happen. So please do take care that you have got a good neonatal team in place and there is a good counseling both before and after delivery. So that will help us. Now, what is very exciting about HELP, and I shouldn't say exciting, but when it comes to serious maternal illness, you need to become a little more, a little more informed and little more clever about having differential diagnosis of HELP. So have you, any of you, come across these other disease entities? Let us have two instances and then we'll go to the next case. Your experience, because it's easy for me to read out the chart. It has no meaning. I mean, everybody has this chart, but I just want you to share your experience and the outcome. I have at least 2 experiences out of this.
AFLP,
It's not about me. I want you to tell. Yeah.
Yes, acute fatty liver of pregnancy I came across in my postgraduate period, madam. The mortality rate is very high, and we couldn't save that patient. And she came directly for this. She was jaundiced, and she came for the delivery. Directly, she came for the delivery, and immediately after delivery, she was pouring like anything. And we have transfused a massive blood, FFP, and everything, and we couldn't save her.
I'm happy, Mohana, that I can give you solutions today. and next time you will save the patient. Anybody else? Kartika, Gomati,
Because she
Karpakam.
was not the booked case, so
I
we
know,
are
I know,
not
dear.
prepared for that patient.
I agree with you that it can catch you by surprise.
Yes.
And if we were not prepared, we also would have lost the patient. Anybody else? Yeah. So we had yeah, tell me. Kartika,
Acute
please
fatty-
unmute.
We had a case of acute fatty liver of pregnancy, ma'am. That patient was also unbooked. She came with intrauterine death. And patient after delivery, she had PPH, atonic PPH, which was managed. So she had a stormy postoperative period and then she recovered.
She recovered. So all stories can happen. So recently, in just not even a month back, one of my colleagues, she referred a case to me to our hospital because she had to travel to US for her daughter's delivery. She could not manage the case, and the case came to us at around I think she was 35 weeks. She was 8 milligram percent bilirubin, deeply jaundiced. She had very elevated, around 100 plus enzymes, high LDH, around 600 to 700. And what was really frightening, very, very frightening, was the INR ratio, was the INR. She had a 3.4 INR, right? And she had hypertension also, the usual picture. She had hypertension along with AFLP. So we did make a diagnosis of AFLP because of the severity of the liver dysfunction, because HELP will not give you this kind of severity. And the platelet count was not very low. It was bordering around 1 lakh. So then what did we do in this case? So we brought in a hematologist before we posted her for section, because my assistant was very, very kind of restless. She said, Madam, please let us post, let us post. I said, let us give her a few hours and then we will post. I think she was around, yeah, she was borderline. She did not need steroid prophylaxis. She was 34 plus. So we gave her some time. What we did, according to the hematologist advices, we gave her cryoprecipitates. We gave her cryoprecipitates, about 5 and 2 FFPs, and we took her for cesarean section. She had some oozing, some bleeding, so we kept a drain and we came out. She did not require any brace suture. She responded to oxytocin. She did not develop any hypotension due to the bleeding. We gave her PRBCs, and in the postoperative period, she made good recovery, but we had to give her FFP. We had to give her cryoprecipitate. We also gave her a prothrombin complex. We also gave her a prothrombin complex because that INR was taking time to normalize. And after 3 days, she normalized but it remained 2.5, then it became 2, and then finally it became 1.2 and 1 by the 4th or 5th day. The liver function recovered very slowly, and till she got discharged in 10 days time, she was still jaundiced, but the enzymes had started coming down and the platelets had started improving. So this was one of the cases of AFLP we had. So in this way, the other hematological complications like TTS, HUS also can present. And some of these will require FFP transfusions. But cryoprecipitate is a little more specific whenever the INR is very high, and in cases of abruption where the fibrinogen is very low. So these are 2 very sure indications for cryoprecipitate transfusion. So any other input? Otherwise, I'll go to the next case. Let me go to the next case.
Yeah. Yes. One more input is the physician. We should not think that physician knows much better than us. Whoever is
Wow.
managing the case, whoever is giving the opinion, we should be the final authority to execute things. Because so many people will come, so many people will give their opinion, but we should be very much thorough because we have the direct responsibility for that patient. And whoever is coming, and they even now the physicians, no, I don't think they have a much better experience than us in
Yes, that's why we must improve as physicians. We must improve as physicians. We must every
We
day
are both,
learn more and more.
yeah, we are both physicians and surgeons, ma'am.
We are both physicians, surgeons, and labor room champions. Who can do that? Okay.
And ICU,
So,
ICU internist and the ICU
yes,
intensive care people
yes,
also we are.
yes. So you become proud of yourself. More and more proud, you'll perform better and better. So this is the lab finding of all these conditions. So as we all agreed, we'll quickly go on to some other. The only thing I wanted to highlight in this last slide is that recurrent help should be counseled for. It can happen in 30% of cases. And then, of course, there is a role of low dose aspirin for prevention preeclampsia in the next case. Even if you have not had preeclampsia related help in this pregnancy, she may be prone for preeclampsia in the next. I think I think that is a reality. So give her a LDA. And primary prevention actually is prevention of pregnancy. So if she has completed family, encourage her not to have any more children. So this is a case of 31-year-old primey, 33 plus 5 weeks, hypothyroidism, and she has some pain, some spotting. She has one episode of vomiting, but there is no bleeding actually. There's no imminent signs. There's no other problem. Now, she had gone to a government hospital and there she fell unconscious. And, she was started with some bag and mask ventilation. They gave some resuscitative measures and then she was referred to us. Now, when she came in, we took some history and we found that she was started on antihypertensive at 7 months of amenorrhea. I'm sorry for the font here. I was not able to correct this slide. She also had some hypothyroidism for which she was taking thyroxine. At admission, she was actually pale. She had edema. And actually, the pupils were dilated because she had been given atropine as a resuscitation in some government hospital. You see what all can happen in unbooked emergencies. And the pulse was very feeble and she was in actually hypotension. The diastolic BP was not even recordable. She systolic was 80. At the period of gestation 33, 34, uterus looked 36, tense, there was breach, there was no fetal heart, the cervix was closed. And then we did a portable ultrasound there and we found that there was a demise, fetal demise around, and there was abruption. So she got admitted to MICU very directly and she was stabilized. She required intubation, of course. And then, immediately the uterus, it was decided to empty the uterus. Hardly we can call it cesarean, but we had to call it that. And, we emptied the uterus. So intraoperative, we saw that it was covalent. So the patient can come in with a covalent address with some history of hypertension. She can directly come with abruption. So preeclampsia remains that kind of a demon where any complication, they can directly come with that. And it's not that they would not have received antenatal care. They might have received, but it might not have been adequate. And she had a dead baby, of course, and she had some 300 grams clot, enough to kill the baby. And of course, there were suture, oozing, bleeding seen from muscles. And we did some hemostatic sutures everywhere. And she recovered. There was a lot of blood loss. Of course, there was a lot of blood loss totally because there's also a clot, etc. So we transfused, we gave her component therapy. Even in the MICU, it remained a very poor circulatory parameters. We see this is how we treated her DIC because she had DIC. We treated with 3-pint PRBC, 4-pint FFP, 1-pint single donor platelet, 1 unit, and 7 cryoprecipitate something. And luckily, she had no transfusion reactions. And slowly, she was on ventilator and she was showing some improvement by day 1. But on day 1, there was hyperkalemia which was detected, treated because she received so many blood products that can happen actually. But she still required noradrenaline and vasopressin support. Okay. And there was some anemia and leukocytosis, and the D dimer values were quite high. what happened in this case, apart from the abruption and DIC, was that she started throwing temperature. And she started throwing temperature. She started throwing spikes of fever, and there was a 2D echo also which was done and shows serious effusions everywhere. All right. Um, all right. So POD4, she started slowly, recovering, and then we found that she started. Uh, we gave her transfusions, etc. She started. So this patient did recover to some extent with the. So what I was trying to say about abruption was that when we have a patient with preeclampsia, even if they are well controlled, but if you have struggled to control, then so I just wanted the panelists here to opine as to what might have been missed in her antenatal care, that she had such a poor outcome. She could have easily died actually. She received too much of treatment in the intensive care. She could have easily died. The baby was already dead. So an intrauterine demise in an abruption indicates that the mother also is at high risk of mortality. And that is what it indicates directly. So we need to have a very aggressive management for her. I just want the panelists to tell what might have gone wrong.
Is she on regular AN checkup? Whether her BP was checked regularly? Whether she was taking the antihypertensive? Because sometimes this uncontrolled BP may cause this abruptions. They can give us surprises. And
of course, complications can happen very suddenly.
yes.
When they develop, I think, when they develop hypertension around 7 months or so, what we must remember is that it is a progressive disease. It is a progressive disease and it can worsen at any time. So maybe the obstetrician initially thought of it as a non-severe preeclampsia. And, so we need to have a closer monitoring, probably weekly evaluation and repeating the labs, etc., so that we don't miss. And also, uh, you know, uh, also look at reasons for termination of pregnancy, because the only way to prevent an abruption is timely delivery, isn't it?
Correct.
Right? Isn't it? So abruption happening, it essentially means that there is something wrong with the placenta. However, maybe the external factor, we may say it is preeclampsia. It is the same pathology, and the placenta is not normal. So such pregnancies will have a bad outcome if we don't deliver them in time. So I just wanted to tell that what was missed here probably was timely delivery. So she should have been delivered probably a week earlier, or at least at the beginning of all the complication. I hope we can go ahead, because cuvellar uterus is a very advanced stage of abruption.
Ma'am, she is 33 weeks plus 5 days only, ma'am. So intensive
Yeah.
monitoring of the BP might would have been helped well, ma'am.
Yeah, something is certainly missed. Something is certainly missed. No, we need to learn something from every case. Otherwise, we can't do anything for the next case, right? We need to learn, because the same thing can happen to us also. We may also miss something sometime, right? So if anybody has missed, we must try to learn from that. That was my point in telling this. Post cesarean eclampsia is another case. This will be the last case, Jairani. I think it is quite late. She's an 18-year-old, so we still see teen pregnancies today. And we all know that they are very prone for complications. And she had 33 weeks pregnancy on 3 times a day labetalol, came with headache and 2 episodes of vomiting. And of course, it looked like she had a good antenatal till then. At 32 plus 5 weeks of gestation, she had raised blood pressure, and she was admitted and given steroid prophylaxis, etc. And the BP was controlled. Now, when we examined, she had a very, very high blood pressure, 200 by 130. Fetal heart was still present. Actually, there was some derangement of LDH and alkaline phosphatase. The urine was 2 plus albumin. Platelet was still maintaining at 1.66. So we started her on injectable labetalol, And we also gave her magnesium sulfate and did an emergency cesarean section. We found some ascites and she did well. Now, what has happened with this patient is after we delivered her, we kept her in the HDU actually because she was otherwise stable. Um, on day 0 itself, after the delivery, the patient had 3 episodes of generalized tonic-clonic convulsions. Okay, and right. So, sorry, Gomati, please mute. Gomati, yes, please mute. Yeah. So she had on the same day she had imminent eclampsia before cesarean. So we gave her magnesium sulfate. We did. We have done everything right? But she came with very high BPs. She already came with a lot of compromise. So we have given her magnesium sulfate. We have done the cesarean. We have ended the pregnancy. Even then, she had 3 episodes of generalized tonic-clonic convulsions. So again, she required magnesium sulfate. She also required Levipril, because by then we involved the neurophysician also because it was looking more like a refractory picture. And we continued all this. Now, what I wanted to tell, because she had very bad hypertension, she needed more antihypertensives also. So actually, it was only after 48 hours that we were able to stop the anticonvulsants. So here, what is your take on this situation? Women who develop convulsions like this after delivery, even though you might have given magnesium sulfate. What do you feel about such cases?
We have to look at that any hemorrhage would have happened, and we need to do a imaging. Definitely, we need to do a imaging. So we have to treat her as an postpartum eclampsia. That is different because we will continue anyway. Maxilf and anti-epileptic will be given, and but the brain imaging is required, madam. Because
few things which we need to understand is, madam, there is always a can be a component complication of any preeclampsia and its aftermaths. And number two is we always think about cortical venous thrombosis even in the setting of preeclampsia. So definitely somebody
Or
needs
even any intracranial hemorrhages or cerebrovascular accident also. We must think of that also.
Yeah,
Yes.
Mona mentioned hemorrhages. So we have to think of venous thrombosis also because the intravascular compartment is always dehydrated. There is more fluid in the extravascular compartment in preeclampsia.
Exactly.
So
CVT is a common
yeah.
problem because they won't take this is immediate after postpartum, but we may see even after some days also because we have a practice here in Tamil Nadu. I do not know about the north. They won't give water after delivery.
Yes.
So they will go for.
It's there everywhere. All Indian communities will restrict water. Even in Bangalore, they will restrict water after delivery and they will come and ask, I'm feeling confused about one thing. Now, what in that? Should I drink more water or should I drink less? Because the whole family is telling her to drink less. So these practices originate from that time when water used to be unhygienic. Drinking water. Safe drinking water was still not available in India for the majority of population. So one either has to boil it 10 minutes, 15 minutes and then cool it and drink, or drink less, whatever is the solution. So like that, those practices have remained, and that is the only thing which, and the rest, the mandatory rest, these are the harmful practices which exist. Otherwise, all other practices like giving more lime and giving that hot fermentation and all are okay, scientific. But this is not scientific. So that is there. What I wanted to bring out here is magnesium sulfate prophylaxis was given in this case because she never had convulsion before delivery, right? She had or didn't have? She had, I think. She had one GTCS.
Yes, she
just
had.
No, before delivery. What did she
it was
have?
impending. She was taken for section for impending eclampsia.
Correct. So she didn't have
headache. For headache only.
Yeah. So even though we have given full dose of magnesium, we have continued it also. So you can, and then eventually it turned out to be just eclampsia. It was not any cerebral cause. So eclampsia in itself also can be refractory to the loading dose of magnesium sulfate. And if you look through the literature, we find that it will prevent Even the MACPI trial says it will prevent 70 to 75% of eclampsia, not 100%.
Yeah,
So that means that women require constant vigilance even after delivery, and that is why we must eclampsia should be treated either in a very well equipped HDU or in the ICU. We should never attempt to keep them in the ward. So upgrading the obstetric unit to a high dependency unit is very essential for managing these cases, because they are at high risk for aspiration. Management of the fit is a challenge. Nursing care is a challenge. You need to have all gadgets for monitoring. So that has become very necessary for such
Dr.
cases.
Shobha, just to
So,
interrupt you in between, I'm Dr. Preeti
hi,
Kumar.
Preeti. Hi.
Shobha, I just wanted to know, do you, if you said you continue magnesium sulfate for 48 hours?
No, in this case we had to, because
No,
she
sometimes
went
in
on.
some cases, if you extend it for 48 hours, are you doing magnesium levels in this case?
No, we will not do, because we will
Just
monitor them.
by saying.
Yeah, we will
Because we
monitor them
usually stop
clinically.
after 24 hours. I don't know
Yeah.
about the other panelists, what are their experiences of using magnesium sulfate. We put them on, either we consult the neurophysician or Levipil, as you mentioned. We change the anticonvulsant, never extend beyond 24 hours. I don't know what is the experience of other panelists.
If there is a repeated convulsion, we will continue magnesium sulfate for 24 hours after the last convulsion.
Last fit, yes.
Mm.
And also half the
24 hours
dose
is
of
okay,
loading.
but if convulsions persist, then we think of giving other drugs rather than magnesium sulfate. This is my opinion.
Yeah,
I don't know what
here even the neurophysician felt that we can give Levipil and magnesium sulfate both. And he told us, you follow your Maxel protocol, and Levipil I will manage. So we continued Maxel for 24 hours after the last bit, which
Yeah,
was
that's fine, but not beyond 24 hours. I am just pointing it out that not beyond 24 hours.
Of the last fit.
Yeah, after the last fit.
Yes. Yes, that's what we did.
Okay.
Thank
The
you,
other,
Preeti.
other drugs like lorazepam, midazolam, or phosphonatoin can be also.
Yeah. This is what
It is not available, ma'am.
Levipil is what is safe and available, and women
safe and commonly
In
used.
emergency refractory
they
seizure.
respond very, very well to Levipil. Yeah. So that is how we manage this case. So any closing comments on this deadly problem?
BP control
Eclampsia?
should be still more aggressive after the delivery.
Yes.
We have to think of the BP. We can even hike up any drug. Even IV hydrolysine can be suggested to control the or NTG drips. NTG drips can be given.
Yes.
That is a very important one. We can continue because that is very important. If you control the BP, her fix will come down. We need not continue the max up too much. That's it. So we can be aggressive with other antihypertensives after the delivery of the baby.
Yeah, control of hypertension will require one path, and control of fit will require a parallel path. Both have to go hand in hand. Control of hypertension, as you correctly said, more options open up after delivery. So in this case also, I think in addition to labetalol, she was started on one more drug. So sometimes they start 2 or 3. Silacar was started for her. So they start 2 or 3 drugs also in order to control the hypertension. And refractory hypertension, high blood pressures, if they are not responding to intravenous labetalol, then as you said, we will do the NTG drip, but again in the MICU setting, not in the HDU setting. So that was how these cases were managed. So any closing comments from all of you regarding eclampsia and HELP, and we can conclude, or AFLP, we can conclude.
So my closing statement will be, don't hesitate to do universal screening. It's for everybody, whether they are 19 or 49 or whatever it is. I think we have to get into the habit of doing universal screening, and by doing a uterine artery PI at 12 weeks booking, at 12 weeks pregnancy, along with the FTS, and with
Justosis score.
Justosis score, correct. Yeah, so we have to do a screening.
Correct. Yeah, go ahead, Mohana.
Yeah, we have to anticipate complications like HELP, abruption, eclampsia in a patient with preeclampsia. So you have to closely monitor and follow up the patient.
Nowadays, BP apparatus are available for cheap rate. So we once we suspect, we treat all IVF patient, all obese patient. multiple gestation. So we anticipate after 20 weeks, if we have even a single reading of 130/90 or something, we'll ask them to take. Seeing a BP once a day, it's not a big deal for them, and they will
Correct.
interestly see. The husband will see, and they will send
Yeah.
the WhatsApp.
Mohana, most
We'll involve.
important. Yeah, very good.
Yeah, we
Mohana,
will
most
involve the
important.
family
Yes.
members. You see the BP daily. If it is more than 130, 140/90, just report. That education we have to give them.
Yes.
So in the initial stage
There
itself,
has
we
to
have
be
to
some
catch them.
pre-eclampsia education for the family. You brought out a very good point.
Because we need to explain them all complications of preeclampsia. Whatever we have seen in our life, we have to tell them.
Because it's not known to them. The
Yes.
concept of hypertension in pregnancy itself is not known to them. Because unfortunately, bad experiences in pregnancy are not shared. Have you had that experience? Miscarriages information is not shared in the community. So whenever there is a spontaneous miscarriage, they come crying so much. And then we spend time in telling them this is not uncommon. 1 in 5 pregnancies will have miscarriage, right? But it's because they think it is so devastating because nobody shares.
Right.
Okay, adverse events in pregnancies are seldom shares. Complication of contraception, everybody will share. But complication of pregnancy, they don't share. So that's why they are not aware. They are not aware. So we have to educate them. You're very right. I just wanted to put in one point when you said, I said, very correct measurement of blood pressure in the OPD. But that has to be done very meticulously. So it's a bit late to define all that, but take home messages. Don't let them go if you have the slightest suspicion. Make them wait and recheck it in the correct way. And then only. So BP measurement is something which should be done by somebody who is trained in measuring the blood pressure. And the instrument should be standardized. Yes, instrument should be. Yes.
We also tell our staff, whenever the patients are waiting in the OPD, they'll just see that 160, 100 and they'll record and we'll make the patient wait there.
They should be brought in front.
Yeah, brought in immediately and inform us immediately.
Yeah. Anything? Yeah, Kartika,
Anytime
Gomati.
severe can become non-severe, ma'am. So, I mean, non-severe to severe progression, we don't tell she will progress slowly. So, we have to be, even if it's a non-severe form of preeclampsia, alerting the patient as well as the attenders, telling the complications and explaining them, and monitoring is very crucial for them. Advising for antenatal checkup every week, after 32 weeks, and 20 to 32 weeks means every fortnightly they should land up, so that we can prevent complications, ma'am.
Yeah, I think we have to tell them the warning signs. Tell them the warning signs. We tell warning signs to even women who are normotensive.
Yeah.
Warning impending. Yeah, we teach our postgraduates. No, so warning signs should be told to all. When we tell them the moment they enter the late second trimester, early third trimester, we tell them, right? Fetal movements, we tell. Then bleeding, leaking, we tell. Pain, we tell. UTI, we tell. Fever, right? And then we also tell them impending signs of eclampsia. Okay, so I think it's safe to wind up. I think we have given enough messages for the day. What do you say,
Dr.
Kartika?
Shobha, just one question from you.
Yeah, Preeti.
Suppose a patient is taken for section for severe preeclampsia and you have given a dose of magnesium sulfate. The delivery happened and everything is fine, and after 24 hours she again has had a fit. So will you like to give a magnesium sulfate again, or would you switch over to other anticonvulsants?
No, I would like to give loading dose of magnesium sulfate again.
Again.
Yes,
Suppose
yes.
it had been already given again.
No, it was given, but we are supposed to continue for 24 hours.
No,
but
no,
in case you have stopped, yeah, we have stopped.
Suppose
and then
today
she
she is
has.
admitted with severe preeclampsia, and you have given magnesium sulfate and you have done the cesarean section, and second day she develops not on the second day, after 24 hours she develops again a second fit. You have completed the dose of magnesium sulfate and again she throws a fit. So would you like to restart magnesium sulfate, or you would like to put her on some other anticonvulsants?
No, I would still like to give magnesium sulfate.
Second dose.
Yes, I would still like to give that as the primary, and then look at other causes and involve probably a physician in other causes, and then see what else
Yeah,
is
definitely
needed.
we'll have to rule out other causes if she throws a fit.
Yeah.
And the last point that I want to tell here is that, you have to monitor these patients in the postpartum period. It's very important. FIGO has come up with latest guidelines on the postpartum care for these women. I think everybody should read it. It's a wonderful article.
Must read it.
Because these women are prone for cardiovascular risk.
Yes.
So the lipid profile, the BMI, the cardiac status, it has to be assessed 6 months and then yearly onwards.
Yes.
So it's a beautiful article. Those who have not read it, please read it, and it's a very informative one.
We'll do that.
Yeah, that's very
Thank you
important.
for that. Thanks for
Long-term
the
risks,
info.
counseling about the long-term risks of
Yes.
real failure
Yeah.
and cardiac
Correct.
problems have to
Even
be addressed.
the
Has
kids,
to be there.
even the babies who are born have left
Yes.
ventricular
Correct.
dysfunction. There are
Yeah.
several studies which are coming up that these babies who are born to pre-eclamptic women, they have left ventricular dysfunction.
Yeah, and they also have eclampsia babies. They are also expected to have neurological problems also. Neurological. So that is another study which is there. Maternal and neonatal neurological problems after eclampsia. So this is a far-reaching consequence. It may be rare, majority may recover, but we need to extend the care. So usually obstetric care becomes a continuum of care. Right? It becomes a continuum. You start with adolescence and you kind of continue it till very late in their lives. So we need to become better and better in that. Jairani, thank you.
Excellent panel discussion.
Thank
Dr.
you.
Shobha.
Thank
And
you,
all the
Preeti.
panelists, gave their insights.
Yeah, I really loved the panelists today. Yeah, so nicely they came out.
Worth
Yeah.
listening.
Thank you.
Thank you so much.
Shobha. Thank you.
Thank you, Jairani.
Muhammad. Thank you, Kartika. Thank you.
Thank you,
Preeti,
ma'am.
and thank you, everybody. Very special thanks to Preeti for all your inputs. And
yes.
Definitely, it is really a very nice, very mind-blowing panel.
Thank you.
Shobha, you made it very nice and interesting with all the important cases, what we clinically, how to manage everything is very practical.
Thank you.
Yes, thank you, ma'am. And last line, I think we are going to have a lot of insight about fetal origin of adult diseases. So everything is going to come down to how we take care of pregnancy and how what the mother eats, what the mother does, everything she does during
I
pregnancy.
also wanted to emphasize on this. The protein is lacking in our Indian diet. We have to improve the protein part.
Maybe there is a lot of dietary problem which we have, which we've not even recognized it. Maybe that is a area of lot of potential research, maybe, but it's a long term thing.
Maybe the food taboos, lot of sodium, lot of this junk food, processed food, they have a lot of inherent sodium, which also has a very impact on
correct.
I mean, lot of PIH coming in this city people, especially the.
Yeah, suddenly there is an increase. So probably, as you said, pizza, pasta, and all is all very bad. Burger. It's all bad.
So
I'm really worried about
so
the
much.
generation next.
Thank you. Very special thanks to Dr. Preeti and Dr. Shobha, Dr. Kundavi, and all the senior faculties. And a very special thanks to Charmila Madam and Suchitra Madam for being with us for all this, sharing their experience and expertise with such a very strong way. Very special thanks to our chief guest, Dr. Narendra Malhotra sir, the guest of honors, Dr. Kiran Mai and Dr. Preeti, for being with us and encouraging and supporting and wishing this webinar as a grand success. And beyond everything, our delegates who have been there watching this, and it is really a very pleasant thing to note. Many of the seniors were commented in our group about the panel and the talk.
Thank you.
Thank you so much, all the senior delegates. And a very special thanks to the senior presidents and secretaries from the UP societies. From we had from Aligarh, we had from Varanasi, we had from Agra, we had from Farizabad, Moradabad, and Bijnor, and Lucknow. Everyone were so much happy to join this, and a very special thanks to all the chairpersons, Dr. Meenakshi sir, Madam Zahra, Madam Nehra. Many of them had given that their link was, their network was not working, and they were apologized. And a very special thanks to all the presidents and secretary of the UP societies and my dear Oxians for being here. A very special thanks to one and all.
Yeah, and
very
all the
special
best,
thanks to
Jairani.
Shield
May
and
victory
Saiti.
be yours. Jairani,
Yeah,
All the
all
best.
the very best.
All the best.
thank you, thank you, thank you
May
so much.
victory be yours.
Jairani, thank you so much.
Thank you, Dr. Preeti.
Correct.
Thank you so
Thank
much
you.
for being with us.
Bye.
It's really
Bye.
encouraging.
Bye.
Thank you,
Bye.
Vananda. Thank you, Shagiti. And a special thanks to Shield for giving us the platform, and a special thanks to Dr. Sri Priya for organizing everything. Thank you. Bye.
Dr. Shobha, we nominate